Very good afternoon. Myself, Dr. Lakshmi Shrikhande, President, Vidarbha ISOPA, and I am host for today's webinar. This webinar is on the theme of high-risk pregnancy, where we have planned two lectures. One on what's new in antenatal care, and second is on RH isoimmunization. And we are very lucky to have fetal medicine expert, Dr. Prashant Acharya, to give a lecture on RH isoimmunization. These two talks will be followed by a case-based panel discussion on obesity in pregnancy. This is the topic which is very close to my heart because day by day we are getting more and more patients who are above their BMI and they are pregnant. So what are the problems in these pregnancies? Dr. Parikshit Tank will be moderating this panel discussion to give us take-home practical messages. So friends, without wasting much time, let us start with our webinar. And our guest of honor is Dr. Sulekha Pandey. Madam, thank you so much for gracing this webinar. She is retired professor and head OBGY BHU Varanasi. Madam has received n number of awards. Madam has published 70 papers in national and international journals, contributed 7 chapters in different books. She is examiner in many universities and she has been examiner 20 times for DNB exam. Madam, the floor is yours. We need words of wisdom and blessings from your side.
Thank you, Dr. Lakshmi, for your wonderful introduction. I express my great pleasure in joining you all on this special webinar organized by our dear Dr. Lakshmi Shrikhande and the members of ISOPAR Mumbai. I also express my thanks to all the dignitaries who are joining us from different parts of India. ISOPAR is conducting regular events in educating and training all our fellow members. Dr. Lakshmi Shrikhande and her team is leading in this activity. I would like to thank Dr. Usha Sharma, Dr. Manju Gita Mishra, Dr. Geeta Ganguly, and all other core team members for such a wonderful organization. Introduction to, now coming to the topic today, Dr. Lakshmi is going to tell us all what is new in antenatal care. I remember my old days when I joined as a faculty in Banaras Hindu University way back in 1974 as a lecturer. We did not have an ultrasound machine. Mind you, nobody can think of that. And we used to wait for all the clinical parameters to diagnose. It was so difficult to diagnose IUDs, missed abortion, anything. But we used to use our both hands and mind and brain to diagnose. Look at the changes that has occurred in the antenatal care. The introduction of new technological advances has dramatically changed the current practice in prenatal care, such as screening and testing of genetic abnormalities, carrier screening, identify carrier couples. Several changes has occurred in early detection and finding the markers in managing the pregnancy with medical disorders. There had been a lot of changes in immunization of pregnant women. I don't want to waste much of the time because Dr. Lakshmi is waiting and with all her knowledge to impart in this wonderful webinar, and let us all hear from her. And once again, I would like to thank you all for inviting me. And I'm really glad to join you all. Thanks.
Thank you, madam. Thank you so much for your words of wisdom and for your blessings. Dr. Parul Kotadawala will join us in a while. Meantime, I would like to acknowledge the presence of our patron, Dr. Milin Shah, who is always there to guide us. Milin, you would like to address? Milin? And I would like to acknowledge the presence of our founder president, Dr. Sneha Bhuyar. She has formed this Vidarbha ISOPAP chapter, and currently she is doing wonderful work as a chairperson of Race Committee FOXY. Milin, are you here with me? Yeah. You would like to say something? Milin?
Unmute here.
आवाज नहीं येत आहे. नाही येत आहे.
Dr. Milind, may I request you to kindly log out and try again? This may be a system issue.
Milin, meantime, I will introduce the Alka and chairpersons. You just sort out your audio problem to save time. I will just move forward. Dr. Alka Mukherjee is our dynamic secretary of Vidarbha ISOPAP. She is having emergency and she will be joining us shortly. The chairpersons for the first talk are Dr. Manisha Ghate and Professor Manju Shukla. Manisha Ghate was secretary of Chandrapur OBGY Society and also the vice president. She is director of Chandrapur Test Tube Baby Center. She is currently the West Zone coordinator of Food, Drug, Medico Surgical Equipment Committee of FOXY, and she has been invited speaker to various national and international conferences. Welcome, Manisha. Professor Manju Shukla, I am telling her she is the evergreen, ever young madam, always there with a smiling face. Hats off to you, madam, for your energy, constant supply of energy. May you be blessed with that energy forever. Madam is retired HOD from the university. She was past president of UPCOG, past president of Lucknow OBGY Society. She is chief editor of the Journal of UPCOG. She is examiner, master trainer, and has got various publications to her credit. So I hand over the mic to the chairpersons to conduct the further proceedings. Milind? So we will start and then Milind and Dr. Parul can address after the first session is over.
Yes, madam.
Yeah.
Thank you, Lakshmi madam, for my kind introduction. ISOPAP Vidarbha chapter is presenting the live webinar on high-risk pregnancy under the guidance of Dr. Lakshmi Shrikhande madam and Dr. Alka Mukherjee madam. As we start our today's session with the topic newer concepts in antenatal care, I would like to introduce, and I am highly privileged to introduce one of the most dynamic personality of and the diva of our Vidarbha and FOXY, Dr. Lakshmi Shrikhande madam. Madam is medical director for Shrikhande Fertility Clinic, Nagpur. She is the national corresponding editor general of OBGY Jogi. She has been clinical secretary, National AMWI. She has received many awards. She is the founder, patron, and president of ISOPAP Vidarbha chapter. She is the immediate past president of Menopause Society, Nagpur. She has been invited as the national and international faculties in various conferences. She is the past president, Nagpur OBGY Society. She has delivered 16 oration and 450 guest lectures. She has many publications in her lined up, and she has sensitized 2 lakh boys and girls on do's and don'ts on adolescent health. So, along with my co-chairperson, Dr. Manju Shukla madam, I welcome you, Lakshmi madam, for your talk. Lakshmi ma'am, the dais is all yours. We all are eager to hear from you. Thank you.
Thank you so much, Manisha, for such kind words. Friends, I am going to speak on what's new in antenatal care. And you all might be wondering what I am going to tell you. Because day in and day out, since last 20 years, 30 years, 40 years, you all are taking care of our pregnant woman. Is there something new? Has really something new come in this field? Let us see. Traditionally, what we all used to do, we used to manage the problems after they develop. So, we used to treat the diseases once the pregnant lady starts suffering from that problem. Second traditional approach was that all the problems, or rather majority of the problems, they occur in the third trimester of pregnancy. So the most intensive surveillance was diverted to the third trimester. I'm sure you all will identify with this pyramid. This is the traditional pyramid where we all used to have monthly visits, then fortnightly visits, and then weekly visits in the last trimester. What has changed? The approach towards this management has changed in the form of reverse inverted pyramid. What is this inverted pyramid? This inverted pyramid tells you that the majority of the problems you can identify and predict in the first trimester itself. So your this broad base, instead of third trimester, it is in the first trimester, that here you have to focus your intensive surveillance of this lady in the first trimester. And in the first trimester, if you divide your cases into low risk and high risk, you all will agree with me that sooner you diagnose that this patient is going to be a high risk pregnancy, the better outcome in terms of maternal care and the perinatal care you can give it to the pregnant lady. Not only inverted pyramid, let us add a basement and a penthouse to this inverted pyramid. What do I mean by the basement? By basement, I mean the preconception care. And what does I mean by penthouse? It is the postnatal care. Don't leave that lady once the delivery is over. It is 6 weeks postpartum is your penthouse. So what is the preconception care? Because ideally we should start from the basement. If your foundation is strong, your building is strong. But I agree, majority of our women don't come to us in the preconception period. But we fertility specialists, we are lucky. All of our patients come to us in the preconception period. They want to become pregnant. They come to us for the treatment. And this generation is very knowledgeable. Majority of my young patients, they come to us that, madam, we want to become pregnant in coming 6 months or 1 year, and we have come to you for preconception counseling. So they are aware of the word preconception counseling and why it is so important. Remember, when your patient is pregnant, she is pregnant with her grandchild. What does I mean by this sentence? Because your patient is pregnant, if she is carrying a daughter inside her womb, that daughter is carrying the eggs with which that daughter will be born. And out of these eggs, her grandchild will be born. So, the eggs that may someday become the grandchild are developed inside the daughter while still she is in the womb of this pregnant lady. And these eggs of your daughter are going to be nourished by the diet and the environment of your pregnant patient. So this is the importance of preconception counseling. In just one slide, I have tried to summarize what all should be told to her in the preconception period. Of course, weight, BP, BMI, lifestyle counseling, Garbh Sanskar, folic acid supplementation, anemia correction if needed, basic tests like sugar, thyroid, endocrine factors if she is having. You have to give her targeted counseling and therapy, and thalassemia screen wherever it is endemic and in high prevalence states. Vaccination counseling in preconception period is also very, very important. FOXI recommends vaccination counseling as a part and parcel of pregnancy counseling. You have to ask her the history of vaccines which she has taken, allergy to any vaccinations, and if she has not received, you have to give her rubella, hepatitis B, and varicella vaccination, preferably in the post-menstrual period. Pregnancy should be deferred for 3 months in case of rubella vaccine. Why we have to do antenatal surveillance? Aren't in old days they used to just get pregnant and deliver at home? Why at all? We have to do antenatal surveillance. Friends, we have to do surveillance because we want to triage mothers into high risk and low risk. We want to screen the fetus for chromosomal abnormalities, structural defects, growth abnormalities. We want to predict and prevent the maternal and neonatal complications. And of course, we want to decide the time and mode of safe delivery. So with these goals, how are we going to proceed towards the surveillance? Let us see. This is a very straightforward case. She has come to us when she was just overdue by 10 days, 26 years old, natural conception, first trimester, first visit. So how you will go about it? She is just 10 days overdue. So you have to confirm the pregnancy. After that, you have to do the fetal well-being, the ultrasound to know that the baby is all right. You have to see for maternal weight, BMI. You have to do urine routine, all routine blood tests in the first visit itself. Maternal blood pressure, focus on having a mean arterial pressure. This is when she is just 10 days overdue. Now the pregnancy has advanced and she is around 10 weeks pregnant. So what is the recommended surveillance at this stage of gestation? I will be telling you the recommended surveillance in all the 3 trimester. First, let us focus on first trimester. The recommended things which we all are supposed to do is do her weight, blood pressure, hemoglobin, blood group and RH typing of both the partners. If you are not doing husband's group routinely, but if mother is RH negative, make it a point to document the husband's blood group and RH factor as well. Do routine microscopic VDRL, hepatitis B, HIV, TSH, DIPSI in first antenatal visit, dating scan, nuchal translucency, dual marker and cervical length measurement. These are the recommended things which are supposed to be done for each and every pregnant woman in the first trimester. You can add BMI, the mean arterial pressure measurement, CBC, peripheral smear, electrophoresis, urine culture, HCV, rubella IgG, thyroid function, thyroid antibodies, vitamin D, HbA1c, Doppler, NIPT and placental growth factor. This is preferable, but this is must. Now let us come one by one the importance of doing the extensive and intensive surveillance during first trimester and what all we can diagnose in the first trimester itself. First, come to the fetal aneuploidies. Fetal aneuploidies is a cause of perinatal morbidity and mortality as well as long-term disabilities. All diagnostic prenatal tests they use to diagnose aneuploidy, they carry a risk of miscarriage and are expensive. Therefore, you can't offer all the tests to all the pregnant women. You have to start with a screening test that has the highest possible detection rate and lowest possible false positive rate. So that is very, very important. So how to go about it? Until the advent of cfDNA technology, first trimester combined screening, that is maternal age and history, detailed history, gestational age, anti-measurement, PAPA and free beta SCG performed at 11 to 13 weeks of gestation was arguably the most robust screening test for fetal aneuploidy available. These combined tests can identify more than 90% fetuses with trisomy 21 and the detection rate for trisomy 18 and 13 is about 95% for the same combined test. The effectiveness of this first trimester combined scan can be further augmented by the addition of other fetal markers such as nasal bone evaluation and Doppler evaluation of the ductus venosus and blood flow across the tricuspid wall. There is evidence that the effectiveness of the first trimester screening could also be further enhanced by including additional maternal serum markers such as placental growth factor and maternal serum alpha fetoprotein. So this was all about the aneuploidies. What about the structural defects in the first trimester? About half of the congenital structural defects can now be diagnosed in the first trimester because of the improvement in the ultrasound technology, because of the measurement of the nuchal translucency, the thickening, and the presence of other ultrasound markers can herald the presence of structural defects, and detailed evaluation of fetal anomaly is becoming widely recognized as an integral part of the first trimester ultrasound. I know we all do an anomaly scan at 18 weeks of gestation, but the early anomaly scan should be done in the first trimester itself. What structural defects we can identify in the first trimester? Once it was recognized that the appearance of anencephaly is different in the first trimester from that in the second trimester, early diagnosis of anencephaly has become routine. However, the diagnosis of open spina bifida has remained a challenge. This situation changed when it was recognized that examination and measurement of structures located in the posterior fossa can provide clues to the presence of open neural tube defects even in the first trimester. Friends, look at this study which was published in 2015 in a prospective multi-center first trimester screening study which included 15,500 normal fetuses and 11 fetuses with open spina bifida. All affected cases were identified or at least suspected by a detailed assessment of the posterior fossa at 11 to 13 weeks of gestation. This was the structural tubal open spina bifida. What about cardiac defects? Can you suspect or diagnose in the first trimester? Yes. The association between congenital cardiac defects and nuchal anti-measurement is very well documented. In a meta-analysis that included 20 studies, the detection rate for major congenital heart disease based on anti-measurement alone was estimated at 44% for a 5.5% false positive rate. Doppler evaluation of blood flow across the tricuspid wall and ductus venosus further improves the screening for congenital heart defect in the first trimester itself. Then the first trimester scan is very important for the exact dating of the pregnancy because the first trimester crown rump length measurement represents the most accurate method of establishing the gestational age in the general population. And the accurate gestational age is a critical piece of information that influences all your decisions as an obstetrician. What about multiple gestations? Friends, first trimester ultrasound is very important here also because you all will agree that perinatal risk of morbidity and mortality is always increased in multiple gestation. However, the level of risk depends greatly on the chorionicity. And this chorionicity assessment is best accomplished in the first trimester as at this time, the ultrasound appearance of a dichorionic diamniotic dividing membrane is vastly different from that of a monochorionic diamniotic membrane. This difference becomes blurred as the pregnancy advances, and the estimation of chorionicity in the first trimester allows accurate counseling regarding the risk of the pregnancy, because if you are diagnosing monochorionic monoamniotic pregnancy, if you are suspecting twins transfusion syndrome later in the pregnancy, you can counsel the parents, they can opt for medical termination of pregnancy. So the determination of chorionicity in the first trimester itself in cases of multiple gestation is very crucial for both the patient and the doctors. Now, I was telling you only about the aneuploidies, the structural defects, the congenital defects, the exact dating of the gestation, and chorionicity in the multiple gestation. What about the prediction of maternal fetal complications? Can we really predict them in the first trimester? Yes. Discussion regarding first trimester screening often focuses only on aneuploidies and structural anomalies. However, maternal and fetal complications that are related to abnormal placentation are much more common than both of these problems combined. Most placental architecture, including placental maternal blood circulation, is established by the end of the first trimester. No further anatomic modifications are evident after the 4th month of pregnancy. And these two facts serve to support the following two assertions. First, the validity of methods used at the end of first trimester in screening for placental dysfunction has a sound physiological basis. And second, in order of any treatment to be successful in reducing the risk of complications related to placental dysfunction, it must be instituted early in pregnancy. And the two often interrelated complications of pregnancy that are major causes of maternal fetal mortality and morbidity are preeclampsia and small for gestational age fetuses. A meta-analysis of 9 published studies have shown that the use of low-dose aspirin reduces the risk of preeclampsia, but only if you start the treatment before 16 weeks of gestation. And you can start treatment so early in the pregnancy if you predict that this pregnant lady is going to develop preeclampsia before 16 weeks of gestation. And this finding was confirmed in a more recent meta-analysis. So there are many meta-analyses which tells you that aspirin has to be started before 16 weeks of gestation to reduce the mortality and morbidity related to preeclampsia. First trimester screening for these complications. Meenal, please mute everyone. First trimester screening for these complications can be improved by using additional markers. One is the estimation of downstream resistance by measuring the pulsatility index in the uterine arteries. Second is the maternal blood pressure measurement in the late first trimester. And third is the evaluation of certain placental product levels in maternal serum such as PAPA-A and PIGF. Fetal Medicine Foundation algorithm suggests that detection of early preeclampsia will be approximately 90% based only on history, maternal blood pressure measurement, and uterine artery PI measurement. The addition of PAPA-A and PIGF level increases this detection rate to the tune of 96%. Please mute all of you, please. Hello, please mute everyone.
Please mute.
So this was all about preeclampsia. I have told you that to the tune of 96% you can predict in the first trimester itself. What about SGA? The risk is increased with an increase in the uterine PI and maternal mean arterial pressure, decreased maternal serum PAPA, free beta HCG, PIGF, placental protein 13, and A disintegrin and metalloproteinase 12 also increase the risk of SGA. For a false positive rate of 10%, the combination of these markers along with maternal characteristics could identify approximately 75% of SGF fetuses who has the risk of delivering before 36 weeks of gestation and 45% who will deliver at term. So to the tune of 75%, you can predict SGA in the first trimester itself. What about the prediction of the risk of preterm delivery in the first trimester? Yes, we all have to make it a habit to measure the cervical length by transvaginal ultrasound in the first trimester itself. What about the screening for GDM in the first trimester? Yes, it is possible. Adiponectin and sex hormone binding globulin are reduced and bisphatin is increased in association with increased risk for GDM. Combination of maternal characteristics and biochemical markers can identify about 75% of pregnancies that will develop GDM later on for a 20% false positive rate. Screening for fetal macrosomia and large for gestational age using first trimester parameters has also shown some promise. Meenal, please support me.
Yes, madam, we are muting. They are getting unmuted.
The risk of LGA increases with
Who, Dr. Rita, who is, please mute, madam.
the The risk of LGA increases with increased anti-measurement, increased levels of maternal serum free beta HCG and PAPA, and a decreased level of adiponectin. For a 10% false positive rate, the combination of these factors and maternal characteristics can predict approximately 40% of large for gestational age fetuses in the first trimester itself. So friends, I am sure by now you must have realized what we all can do in the first trimester itself by ultrasound, by Doppler, by biochemistry, by taking a detailed history. We can diagnose to the tune of 93 to 96% of problems which are going to manifest later in life. What about the second trimester surveillance? In the second trimester, the window is 18 to 24 weeks. The recommended things are repeat blood test, hemoglobin, TSH, urine dipstick, DIPSI, quadruple or triple marker, do anomaly scan and repeat the cervical length measurement. Preferable that you should add NIPT, uterine artery Doppler, 3D, 4D scan and fetal echo at 22 weeks of gestation. Asymptomatic single pregnancies with a TVS of cervical length of less than 25 millimeter in second trimester, you know that the prognostic value of the prognosis for this measurement. Screen at 11 to 13 weeks with transvaginal ultrasound and then repeat at 22 to 24 weeks so that you can predict the preterm labor, the chances of preterm labor in this pregnancy itself. The recent evidence says that cervical stitch does not help and progesterone alone may be the treatment of option for preterm labor, but this should be individualized on case-to-case basis. So friends, with this combined first and second trimester screening, the detection rate increases to the tune of 97% with false positive rate of just 2.5%. Vaccination in pregnancy should never be forgotten in preconception period as well as when she comes to you when she is already pregnant. She should be given 1 dose of tetanus toxoid, Tdap or triple vaccine, second dose at 24 weeks. Influenza vaccine you can give from 24 weeks onwards. Hepatitis B can be given if she is not immunized. Targeted vaccine in case if she is planning to travel to endemic areas, and in the postpartum period, do counsel her for HPV vaccine. In the third trimester, the recommended are the repeat blood test, urine dipstick, TSH, DIPSI, growth scan, Liker assessment, placental localization, and the fetal movements. Preferable is that you should add color Doppler, CTG, the BPP, that is modified the biophysical profile, and Doppler velocitometry. In the third trimester, the fetal surveillance takes the crux of our surveillance because we want to assess the fetal well-being in utero before the onset of labor. Early detection of fetus at risk we want to identify so that timely management to prevent further deterioration can be taken. There are various methods for antepartum fetal surveillance. I just want to add one slide on a very common thing which we all should counsel our patient about the kick chart. She has to count the kick count 10 movements every day, should be around 6 in 1 hour. If she is feeling less than 6 movements in 2 hours, she has to report to you for further assessment. This is available on the net. You all can have it in your native language. You can give it to the patient so that they understand what you are talking of and they can coordinate with you and cooperate with you in having a proper kick chart. This is the Foxy recommendations. We had the older ones in 2019. This was modified again in 2017. So we have the list for mandatory things should be done and preferable, that is things which can be done add on to the mandatory things. So up to 10 weeks, Foxy recommends hemoglobin, blood group RS typing, screening for infections, urine routine, blood sugar, and at 11 to 14 weeks, NT scan. Preferable up to 10 weeks, you should do CBC and peripheral smear and TSH, dating scan, and at 11 to 14 weeks, on top of ultra anti-scan, you add double marker to it. At 16 to 18 weeks, it is preferable to do a triple marker. 18 to 20 weeks, do a detailed anomaly scan. 24 weeks, do the GTT. At 32 to 34 weeks, repeat hemoglobin. And preferable is that you should do urine routine, ultrasound, growth scan, and at 38 to 41 weeks, do ultrasound. I'm sure we all are doing much more than this, but this is the very, very basic things which Foxy recommends for each and every pregnant woman in first trimester, second trimester, and third trimester. So friend, this is the last slide, that what we all can do in the first trimester itself. We can diagnose the fetal aneuploidies so that you get time to counsel the patient and patient can have time to decide whether they want to continue or abort the pregnancy. You can identify the structural defects, neural tube defects, the congenital heart defects. You can decide the chorionicity if she is having the multiple gestation. You can do exact dating of the pregnancy. Not only that, you can predict many of the placental dysfunctions like preeclampsia, because you have to predict it before 16 weeks so that you can start low dose aspirin. You can predict gestational diabetes, fetal growth restriction, the chances of preterm delivery, and if she is Rh negative, don't forget to add indirect Coombs test at the first antenatal visit, and in first trimester itself, if you predict, it will help you in giving the best possible outcome to this pregnant lady. So friends, again I am coming back to my first slide. Traditional is this pyramid, but now what's new has come is that inverted pyramid, and to this inverted pyramid you have to add the basement, that is preconception care. Don't forget to add the penthouse, that it take care up to 6 weeks of postpartum. Because I will say, not only a child is born when she gives birth, but a child gives birth to a mother, and let this be a very, very pleasant journey for this pregnant lady by giving her the best possible chance in the first trimester itself. So thank you friends. Thank you so much for your patient hearing. If there are any questions, I will be more than happy to answer.
Lakshmi madam, I have one query.
Yes.
Ma'am, what advice we need to give a pregnant lady in pregnancy and in preconception regarding the COVID vaccination?
Vaishali, there are so many papers which tells you that it is very safe, but as of now, Government of India tells you not to give, and we have to follow our government guidelines. I would like to have inputs from Prashant. Prashant, please unmute yourself. And the whole nutshell, what I spoke, if I miss some point or you want to emphasize some other points.
Yeah, I will emphasize during my talk. I'll show a couple of slides in the addition of what you said. But
Okay.
you can give explanation. There is no problem. Technical, there is no
You
issue.
can give, but Government of India tells.
Unless if you feel like that government is saying no, so I shouldn't give. That's one way of thinking. And what my science says, yes, you can give, because I have got a lot of references. So if you have got a very bad luck and patient dies after vaccination, you are in problem. So if you want to be safer, put a word of caution. I mean, government says no, but you can take. Put a counsel.
Yes, it is safe during pregnancy and lactation both.
Indian government says no, but you can take.
Yes.
It has to be.
Yeah, Lakshmi, I think if you remember, few days back we had this debate as well. Yeah, but there are studies which are coming up. Even recently, there was a very interesting case that antenatally a lady has taken the vaccine, and the baby has was found with good antibodies which were protective for COVID. So then also we had a discussion that yes, you can take it during pregnancy as well as breastfeeding, that is during lactation. So, but I think as far as we talk about this medico-legal era and self-protection as a practitioner, then that's the reason we follow the Indian guidelines, I think.
I tell you, Dr. Sneha, there is also there is a problem when a baby has got a huge amount of antibodies. It can also lead to multi-organ failure in the baby itself. So
Correct.
that good high quantity of antibody is not something which is really very good. So don't consider that as something which is of advantage. It can lead to multi-organ failure in the baby. Okay, so these things are also keep in mind, and try and make it more counterbalance system. When till now we do not know, put it in front of them. Yes, at the moment we don't have that much of data. If you are very conscious about corona, take it. That's it.
Yeah.
Yeah.
Dr. Shalanya, same thing we are discussing. There is one question in the chat box. In the lactation period also it is very safe. But as of now, GOI recommends that it should not be given during pregnancy and lactation.
6 weeks after lactation.
Now Dr. Parul Kotadawala has joined us. Welcome, sir.
Welcome.
Now let me introduce our guest of honor, Dr. Parul Kotadawala. He is really shy. I had to really push him ki you have to come. And I'm
Dr. Lakshmi, I just want to make one comment.
Yeah, please.
In UK, they are giving vaccination to the lactating women with the informed consent. So you inform if the mother is ready to take the risk of the COVID versus vaccination, it can be given. So my daughter got it. She is only 6 weeks breastfeeding. She had her first dose of vaccination. So it is all informed consent. So you inform the problems, and if she agrees that she thinks that she is at more risk of taking COVID than the vaccination, then it can be given because the datas are there. So I will say that it is always safe. Like hepatitis B, we said we cannot give. Now we say that it should be given because it has got more advantages than the disadvantages. So it all category 2.
Yes, thank you. Before Dr. Parul logs out, Dr. Parul, I welcome you for this webinar of Vidarbha ISOPAP on high-risk pregnancy. Currently, he is Vice Chairman of ICOG and Vice President of National ISOPAP. He was Vice President FOXY way back in 2006. He was President SOGOG in 2009. And he has purposefully, I think, not mentioned many points in his CV. He is a great endoscopic surgeon, a great academician, and an orator par excellence. He has got many publications to his credit and is regularly invited to deliver talks on mainly endoscopy, I believe. That is his passion. So the floor is yours, Dr. Parul.
Thank you, Dr. Lakshmi. You are always very generous in praising others. Well, I first of all apologize for joining a bit late, but I was detained in the passport office and I had no choice. Well, I am very thankful to Vidarbha Society of ISOPAR to ask me to be a guest of honor. I was wondering when would in one's life one will be called to become a guest of honor, and I thought perhaps there are only two factors. Either one is too old or maybe one is holding a senior position. In my case, perhaps a combination of this has worked, but I accept it with reluctance.
I know. I was after you because you are national vice president of our national ISOPAP. So in that capacity.
Well, I looked up the program and it is really superb. You have chosen all the current day topics, starting with your own topic of new concept in antenatal care, and then RH by Prashant, and then a power panel of a very important topic of obesity in pregnancy. And I'm sure that Parikshit will be doing a good job on that. I also compliment Vidarbha chapter for being one of the most active chapters of ISOPAP. See, Hyderabad has been very active since many years, but these three new chapters, and Patna as well, because the head office is there and most members belong to Patna. But Gorakhpur and Vidarbha are really doing a great job, and I compliment them for that. And Lakshmi is the live wire person behind this. In last 1 year, I have noticed that, and I wish you all the best and a very active year ahead. Please continue with the
Parul
program.
bhai, the credit goes to Milind, our patron, and our founder president Sneha. They are always there to guide us, encourage us. So Vidarbha Isopap is a teamwork, and yes, I am happy. I am reaping the fruits of their hard work and labor. And they both are here, and I am thankful to both of them from bottom of my heart. Manju madam, please, your expert comments are still pending on my talk.
On your talk, you have talked so very well that comments are very few. I was saying that old wine in new bottle, but it was new wine in old bottle, because the importance of antenatal care everyone knows, and they really, there are researches going on making antenatal visits from 4 to 8, so that to reduce the perinatal and maternal mortality, and identify the, as you said, importance of ultrasound and uh, quadruple marker and double marker, so that we can diagnose many congenital problems early and have termination. So, Lakshmi, it was very, very nice, very explanatory talk, and there is nothing to comment on it except that WHO recommends 8 visits most probably, na? So now in class we always teach 4 visits, but we have to tell them now that it is 8 visits.
First trimester, Manju madam, we don't have to call patients so often. Only thing is that the mindset of the obstetrician has to change.
First trimester,
You don't have to call them weekly.
First trimester is first contact. Whenever she
Yes.
is the period to have the investigations you told. And DIPSI recommends
Yes.
75 gram glucose testing in first visit, and then after that 26.
Yes.
So thank you for inviting me.
नहीं, आपको देख के बहुत अच्छा लगता है. थैंक यू सो मच मंजू मैडम, मनीषा, पारुल भाई. थोड़ी देर रुके, अगर आपको काम नहीं होगा तो. सुलेखा मैडम, थैंक यू सो मच.
Thank you very much.
Let us move to the second session, and I would like to introduce the chairpersons for the second session, and they are Dr. Manisha Barmade. Just a minute, Manisha. Manisha is from Latur. She is practicing there since 12 years in the Barmade Hospital, and she has won many awards, and she is currently the member of Adolescent Health Committee, and her area of interest is high risk obstetrics. So welcome Manisha. And Vrishali Mane is the chairperson for this session. She is currently the vice president of Yavatmal OBGY Society. She is executive member of Adolescent Health Committee of FOXY. She has won many awards, presented papers, and she has contributed one chapter in FOXY Focus. So welcome Vrishali and welcome Manisha. I hand over the floor to you for further proceedings.
Hello, madam. Good evening, all. I would like to invite Dr. Prashant Acharya, sir. He is a consultant in fetal medicine and high-risk pregnancy care. He is a mentor, guide, and teacher. He is having a diploma in ultrasonography, diploma in pelvic endoscopy, and trained at King's College Hospital, London, England. He is the first Asian to be inducted as a ISOGS board member, and he is also appointed as ISOGS ambassador for India and South Asia. Today, sir is guide us on a RH isoimmunization. So, I request sir to guide us.
Prashant, you have purposefully given only 4 lines in your CV, but friends, let me tell you, he is a master's in fetal medicine. He is running the training courses in the fetal medicine. We were co-vice presidents of FOXY in 2012. A humble, down-to-earth Dr. Prashant, and a great human being. So Prashant, the floor is yours, and we are eagerly waiting to listen to you on RH isoimmunization.
Thank you, Lakshmi. Hope I am loud and clear with all of you now.
Yes.
Now this is my CV. It's just thank you for your kind words, but at the moment, I would like to put across a couple of things that I was ISWA board member between for 4 years. I was the first Asian to be appointed, and I've been awarded this prestigious ISWA fellowship in 2019. That globally till now, only 29 people have received it. So fortunately, Kipros is all Ravi Chavi and all. They are one of those groups. So fortunately for me, I got it last year. Thank you very much for inviting me here by Vidarbha Society for ISOPA. And 2021, it's all because of invent of good ultrasound quality technology. We could see the features. We could see the features in details and very much in detail, so that we can diagnose so many of malformations. And the moment we diagnose the malformation, next step is, as a physician, we will always think about the treatment. And that's the reason the fetal medicine as a branch not only diagnoses, but how to treat these fetuses and how to evaluate these fetuses, how we can improve their health once they come out in this world. That's what the branch fetal medicine is all about. Let me add some points to the Lakshmi's talk, because she had said something to add me. See, if you see on your left side of the screen, that's a typical pyramid which Lakshmi has shown it to you. Once in 3 months, then every month till completion of 7th month. Then we ask her to come every 15 days. Then in the last month, every week. So we usually ask her for the 9 and 3, 9 and 12 and to 14 visits. But now what the concept is, we ask them what we call is the tube of pregnancy care. One is at 3 months, one at 5, one at 7, and one at 9. These are the 4 visits where we can make decision making in this pregnant ladies. And our concept is at 3 months we will be doing 13-week scan with an early anomaly with cell-free fetal DNA. Cell-free fetal DNA will roll out the trisomy 21, 13, and 18 up to 99% accuracy. No other aneuploidies which will be predicted for even by this NIPT. So make sure that you want to evaluate 13, 18, 21. NIPT will work. But an early anomaly, all sorts of lethal malformation can be diagnosed by 13 weeks. The next has to be around 22 to 23 week scan. TIFA, there are 6 segments of it. I'll show you in my next slide. But next has to be 28 week. Will be able to diagnose late developing anomalies and early fetal growth restrictions. And 34 week, where I would like to do my scan to detect whether this lady needs early induction or not. So that's what will be needed. But I would like to add one point. When you are evaluating that lady at 11 to 15 week scan, not only do TSH, but add free T4. Because adding T4, free T4 is the thyroid hormone which is going to go to the fetus, and that is where I would like to add that point. Second thing, whenever you find your TSH high, make the TPO antibody and diagnose whether this hypothyroidism is because of antibodies or not. If she is TPO positive, then these are IgG antibodies and they will go to the fetus inside. They will cross the placenta and they can create the fetal hypothyroid. And that fetal hypothyroid will only lead to this low IQ, what is being in what we consider as a low IQ because of the hypothyroid. That is only because of this crossing of the thyroid antibodies. It will cross the placenta. It will go to the fetus. It will attach to the fetal thyroid, and then we create that hypothyroidism. These are the 6 segments what you should evaluate by default, and by 7th month, these are the same segment. I would like to see late developing malformation, and I would like to evaluate the fetal growth. And in 34, 36 week, it's that color Doppler. As Lakshmi said, it is color Doppler velocimetry, but it is different. When you find fetal growth, early fetal growth restriction versus late fetal growth restriction, the entire management is different. And now it all depends upon at when you have diagnosed, what are the vessels which are involved, and you should take management like this. In a twin pregnancy, dichorionic and monochorionic, again the management is different with a singleton and monochorionic and a dichorionic. This is a special for the monochorionics. They are different. I have just put it a slide. You can go through this slide later on, take a snapshot of this, and you will be able to understand this because you are dealing with possible TTTS, selective fetal growth restriction, and the special malformations regarding the monochorionic twin. Now I will go to my original talk. Now, almost 90% of us, when we do possess we do possess an ultrasound machine, we think that color Doppler has to be there, and that's the reason. We have a color Doppler. And now, if you have color Doppler, and if you don't do it in Rh negative mother, this is what we end up in this situation. We have resource, but we take a poor decision in not using this. So we don't want to that situation, but you have to learn how to deal with those kind of situation. And Rh negative management and fetal transfusion, that is one of the most satisfying and most successful in utero fetal intervention, and it takes care of so many of the things. Now, incidence of Rh negative mother is 5 to 7% of our Indian population. Particularly, they are more common in Caucasian population, but it is very less in Far East. That's Japan and China, practically zero. But you go more towards the West, the incidence of Rh negative blood group increases. So we are dealing with 5 to 7% of population of us, and that's the reason it is important to know how really you should manage these Rh negative mother. Is she special? Yes, she has got a very special status because there is a difference in antenatal management, there is a difference in intrapartum management, and there is difference in the postpartum management. Now my aim of antenatal managements are simple. I must know her immune status, whether what is her indirect cumstase is positive or indirect cumstase is negative. If indirect cumstase is negative, that means she is not isoimmunized. My aim is to prevent her getting isoimmunization. And if mother is already having indirect cumstase positive because of some reason, my aim is to detect fetal anemia and hemolysis and prevent fetal complication inside utero. I cannot treat this immunization because it's not possible, because that lady's body has developed those antibodies, that mother has developed those antibodies. So these are my three aims. So we will discuss this. Now, before going to that, we need to diagnose, understand what is the genetics of Rh, because the Rh gene, Rh is a protein. It is attached on the surface of red blood cell, and that antigen has, because it is a protein, it has to be synthesized by one of the gene, and that gene is located on chromosome number 1. And there are practically 5 genes responsible for this, and these 5 genes are practically C, D. There are only one capital D, small c, capital C, small e, and capital E. Now these RBCs, which starts forming right at 37th week or 37th day of the gestation of the conception. That's the reason in the ectopic pregnancy, what these RBCs are there. Because the RBCs are there, it will have the surface antigen, and it can lead to the isoimmunization. So it is not only this D. D will give you, well, if there is a capital D in your body, that will give you Rh positive status. But there are many other antibody, KEL, Duffy, MSN, and there are A, of course, our blood group A, B. These are the 2 there. If A, B are not there, you are of an O group. If both are there, you are AB. If your only A is like A and B is B. So apart from that, these are located on various number of chromosomes. Now I have given a list of systems which are there, but it's not important for you. But for us, it is not only fetal anemia or indirect cumstase is not only because of these capital D or small d. There are many other problems. Now, because we have chromosome number 1, 2 in our body, so there are possibility of 2 capital D on our system. If you have got 2 capital D in your chromosome, on both chromosome number 1, you are called as a homozygous Rh positive. If you have got only 1 capital D on only one of the chromosome number 1, because chromosome number 1 is impaired. So if both are there, you are homozygous. If capital D is attached only on number 1 chromosome once, you are called as homozygous Rh positive. Now, because this is important, because if a husband is homozygous Rh positive, all the siblings, all the siblings will be having Rh positive status. And if husband is heterozygous Rh positive, he will have 50% of them, they are going to be negative and 50% are going to be positive. Because we are discussing Rh negative mother, because she is Rh negative, she will not possess any of these capability on her any chromosome number 1. So apart from this, let us understand this, what is the pathological mechanism. When these Rh positive RBC enters into the mother from the fetus because of any of the reason, any of the insult, it includes termination of pregnancy, postpartum delivery, or any invasive procedure after the invasive procedure. But these RBC will create antigen antibody reaction because maternal immune system will consider these foreign Rh positive status as a foreign body. And because they will create first instance IgM, and then on a second insult, they will produce a huge quantum of IgG antibodies. Once these IgG antibodies are produced, because IgG antibodies are small in molecular weight, IgM antibodies are larger in molecular weight, IgM will not cross the fetoplacental barrier, but IgG antibodies, because they are small in molecular weight, it will cross the membrane, it will go to the fetus, and they will attach with the surface of the RBCs, and they will destroy the cell membrane of the RBC. And these destruction of cell membrane will lead to hemolysis, and these hemolysis will lead to the hepatosplenomegaly, eventually the jaundice, but also a hemolytic anemia. And these anemia eventually will lead to severe hydrops, cardiomegaly, and all sorts of complications that you know. But the aim is these initiation of the immune mechanism that will be happening across because of any of the reasons. So that's the pathology we have understood. During antepartum period, this insult can be because of many reasons, that is silent, or because of the blunt injury, or because of any antenatal period. Intrapartum, that is what we consider as one of the most important. And now, as we know that it is there, that it is going to have some amount of the fetal RBCs which will enter into the metal circulation. But usually, what we consider as that 300 microgram, which will be covering 99.2 to 99.3 normal deliveries. It is normal deliveries, okay? So during special kind of procedures, maybe because of the instrumental delivery, cesarean, manual removal of placenta, intrauterine death, or abdominal trauma during third trimester, will lead to more quantum of the fetal-maternal hemorrhage, and their 300 milligram of single shot may not be sufficient. And especially because of the twin pregnancy, you have got a large placenta and large quantum of blood may go through. So these are the special situation, will require a larger dose, and that's the reason ideally you should calculate the fetal-maternal bleed and calculate the dose, and that's how you should cover that lady. And if at all you have got some doubt, no facilities, you may think about increasing the dose rather than 300 microgram for the multifetal pregnancy, particularly instrumental delivery or the cesarean, where you have encountered with a larger quantity of the fetal-maternal bleed. Now there is a recent upsurge. In Rh ionization noted, probably because of the availability of oral abortifacient drugs that is available over the counter, and that's the reason people take it from the counter. They get aborted, but eventually end up in Rh ionization. That's the reason there is a recent upsurge in the system. Now, why as I told you, antenatal mother is a special. Now, antenatal management, how we have to carry out. Of course, we have to carry out husband blood group when we find mother is negative. If husband is negative, I'm not worried. But when husband is also positive, mother is negative, what I should do is I will determine at the first visit I'll get her indirect homocest done, and then next as 26 and next at 32 weeks. Because patient has given a history that she is primary gravida. She may have some kind of history which she may not want to disclose it to you. So that is one possibility. Second possibility, she may had previous some blood transfusion with an Rh positive. Eventually will lead to this positive immune status, but we would like to investigate that on the first visit. If she remains in ICT negative throughout the pregnancy, No active intervention is required except antenatal prophylaxis and postpartum prophylaxis. So that is where we can offer her 300 milligram at 32 week as a single shot, or 2 shot of 150 or 50 milligram at 26 and 32 week. That's what should be the antenatal management. Now, if she has got, she is NTD, I mean RH negative, we have covered her for antenatal prophylaxis. Now, how during prophylaxis, how can I prevent this isomnization? How can I do antepartum prophylaxis to her? Now, the NTD, as you know, that it has to be, first I should calculate the total quantum, or how much the dose she will be requiring. And then once I calculate the dose, then what I should do is give her antibodies, these NTD injections, not only the gluteal muscle, I will like to give her in the deltoid muscles only. So no gluteal muscle, it has to be given on deltoids, no gluteal muscles. Now, ideally, Clahor-Batke is such a simple test, very simple test. Just add on KOIs to the dry slide of the peripheral smear, and you can calculate how much fetal RBCs are there, and then try and evaluate, calculate the dose. Second, when, if at all, I want to do it, I want to do Clahor-Batke, collect this blood 45 minutes after the insult, so that I can have a precise dose, how much she will need. If the dose are not available, then standard dose of 300. If some insult, I would like to add on more dose, in particularly with this. There is a debate about monoclonal or polyclonal antibodies. Monoclonal is what we are getting a rogue clone, because they are manufactured in the factory, because it carries a single monovalent kind of coverage which is there. Polyclonal is from the human source, but it covers many other different kind of antibodies. But it can have infection. Monoclonal will never carry some hepatitis B or C or some kind of HIVs or any strain, but it has got, both has got their own advantages and both disadvantages. It is itself in a separate lecture, how to choose, what to choose, and how we can calculate about this monoclonal and polyclonal antibody. If time permits, we'll discuss that point in detail. But for successful prophylaxis, NTD should be given as soon as possible, and that too within 72 hours of the sensitizing event. But whenever, if you forget to give this within 72 hours, give up to 9 to 10 days, that lady may have some good kind of antibodies till that time. A lady with indirect Cumstes, never give her NTD injections, because she doesn't need it, because the entire aim won't be getting fulfilled. Now we have discussed a clinical scenario where her indirect Cumstes is negative. But when a problem is that lady comes with an indirect Cumstes positive, one of the most important point is, you can win with this still situation also, but you need to know how you are going to manage that lady. How are you going to identify the problem earlier for your better outcome? Now, she has come to you in her next pregnancy. Previous cesarean section, NTD given, may not be sufficient dose, and now in the next pregnancy, she has come to you. On the first visit, you know that indirect Cumstes is positive. How are you going to evaluate that lady? Simple system. Now, what you are supposed to do is ICT positive and the titers. What we say that 1 in 60, 1 in 32. What you call it as a serious matter. There is nothing like that sort of system. Indirect Cumstes positive, she is positive, and that lady can develop any amount of fetal anemia. But remember one thing: if you get these ICT titer rising up to 4 times after a month, that means the antibodies are going up in the maternal body, and baby, there are more chances of baby is going to get fetal anemia. Get husband genotype for RH. If that her husband is homozygous, that means both carries capital D on chromosome number 1. All fetuses are going to be RH positive, and they will need some kind of in utero intervention. If heterozygous, 50% will be RH negative. So your job is to identify whether this baby inside is RH negative or RH positive. And if RH positive, they will develop anemia. RH negative will never develop fetal anemia. So that's how you can identify in utero without intervention. Now titer has got no value. 1 is to 16 or 32, both are same. But what some of the books, some of the references, 1 is to 32, we consider that as a critical titer. But no, it's not like that. It's about the virulence of antibody. If there are more virulent antibodies with a less titer, still they will create fetal anemia. And occasionally a high titer with less virulent antibody, they may not cause any fetal anemia. So now you have got a third clinical scenario where a lady comes to you that previously she had history with a hydrops fetalis and baby has died in utero, or after the birth baby had hydrops and after exchange was done and still baby died. Now that has got a different kind of outcome and a different kind of investigation. Here, one of the most important point is in past obstetric history is predominant indicator of a current pregnancy outcome. Now remember one thing, whenever that lady gives you history that at 26 weeks she had hydrops, I'm giving you one arbitrary situation. At 26 weeks she had hydrops. So what's the problem? Hydrops is developed when fetal hemoglobin falls below 4 or 5 grams. That means a normal fetal hemoglobin, which should be 15 gram, it has fallen to 5 gram. So the 10 gram of hemoglobin has reduced. One simple thumb rule is at every week 3 gram of hemoglobin can fall. So that means that the process of the fetal anemia was started 6 weeks before that insult when that lady came to you with the presentation of the symptoms. So if she had 26-week hydrops at the present pregnancy, that means that the lady must have started the fetal anemia sequence 6 weeks before. That means by 20 weeks. So during this pregnancy, I will expect that by around 18 to 20 weeks, this lady will start developing the baby will start developing fetal anemia, and probably I should have intervened much earlier. Second scenario, post-delivery fetal anemia, hydrop exchange, and all sorts of consequences. In that case, I would expect that by 24 or 26 week or 27 week, baby will start anemia. I may need to have intervention at that time. So it's all depend upon the previous history when baby was affected. You need a frequent follow-up of middle cerebral artery peak systolic velocity. Transfusion can be offered as early as 16 weeks, and watchful for fetal evaluation when fetal gestation reaches 6 weeks before last mishap. That's what I have discussed that. Follow up with MCR Doppler and delivery, and whenever your neonatologist is comfortable. This is a flow chart which you can take a snapshot and you can go through. This is what we are going to discuss right now. Now, fetal anemia, as you understand, that is one of the worst complications, and our job with the Doppler is to diagnose whether baby is having anemia or not, because once apart from this, why it is better to diagnose fetal anemia before it develops hydrops. There are simple reasons that if the baby is already hydropic, there are 40% of survival, and if there is no hydrops but baby is anemic, and if you treat that baby, there are 85% of the survival. So there are although lot many other cases of fetal anemia, but at the moment we are discussing RH, the entire concept is like this. So my job is to diagnose fetal anemia before hydropic changes occurs, and because I want a better outcome, and because I do have color Doppler, my job is to identify these much more before. Now, as you told, now let us understand what I should understand. As you know that it is all about the Doppler, and Doppler is a mechanism where it evaluates the number of RBC which are flowing across that parallel gate where we are putting it on the vessel. So it's about these Doppler which we are assessing the flow of RBC through that. Now, what happens to the flow during the Rh negative mother or fetal anemia? What happens? As we know that baby becomes anemic, am I right? So quantum of RBCs are less. Quantum of RBCs are falling below. So the viscosity will be going down. And because viscosity is less, I'll give you one simple example. You have got in one bucket, you have got full of tar or oil, and in one bucket you have got a water. If I throw with the same speed, water will go further away and oil or tar will not go that far away, because One is having more viscosity on coal or tar. The water has got less viscosity. Less viscous will create more velocity. And this peak systolic velocity is nothing but the velocity of RBC. So the higher is the velocity, thinner is the blood. Thinner is the blood, that means anemia. Fetus is more and more and more anemic. So what is typically known as that whenever baby is, I will show you one in my next slide how to take this. There are few very strict criteria. Once you are having, look at this, your middle cerebral artery, circle of Willis, that's the gate. I would put it across with the angle correction. If you see this yellow line is parallel to this middle cerebral artery, I will put 1 centimeter away from the origin and try and get. I am evaluating, this is 26 week 5 days. Let us see this. I'm putting it on the middle cerebral artery. I have just taken a Doppler, and then what I am going to do is I'll just measure what exactly the velocity is. It's an auto calculation, right? So I'm sorry, I've skipped to my next slide. So I'll try to go there. So here it is showing me, it is showing me that what I am dealing is with 55 millimeter of peak systolic velocity at 26 week of gestation. So this is what I need two things: gestational age and middle cerebral artery velocity. So this is mixed peak systolic velocity. Gestational age, it was 26 week. So at 26 week, I will put it 52 here. It is falling in zone B. And so that is moderate to severe anemia. Zone A is mild anemia, and this is median. So thumb rule is there. Whatever gestational age it is, if the middle cerebral artery peak systolic velocity is double, so at 20 week it is 40, it is above in this zone, and if it is 25 week, 50 is in this zone. 30 week it is 60 is already is in this zone. 20 week it is 40 is already in this zone. So make sure that you have got double the gestational age, that baby needs a transfusion, and this is what the thumb rule is, and this is what a Marish chart. And while clinical examination, if your peak systolic velocity remains straight, that baby is not anemic. Either baby is not anemic or the baby is Rh negative. But in other case, if the peak systolic velocity goes up, increasing, that by this examination, what you are dealing with, if it starts growing like this, in this case, what you are dealing, that baby is anemic and it will need transfusion, and this is what is going to be your evaluation. Couple of systems: intravenous you can give, intraperitoneal you can give. Intravenous is an ideal situation, and the best point is the placental insertion, placental cord insertion, because it is relatively fixed point and I can put my needle right there. And how am I going to do? There are couple of things. How much quantum I should give. There are softwares which will give you the exact calculation, how much quantum. There are few equations are also available. But I would like to tell you one thing: if you want to start doing it, the best is intraperitoneal transfusion, because you have got a larger surface area. You can put needle in the abdomen and you can inject. How much to inject? Subsect 20 from the gestational age and multiplied by 10. So for example, you are dealing with 24-weeker baby having anemia without ascites, then 20 you have to 24 minus 20, that is 4 multiplied by 10, that is 40 ml. You require 40 ml, and how to give, I'll show you the video. This is what your needle is. If you can see this at this point, this is my tip of the needle, and this tip of the needle will go right behind the anterior abdominal wall, and then I will start injecting the RBC, and these RBC will probably create, this fluid will create artificial ascites, and these artificial ascites will be created. I will go on creating these artificial ascites till the desired quantity is being given. Now, giving intravenous transfusion, there are a couple of things I would like to tell you. That it is if you are lucky, you will have anterior placenta and umbilical vein. So I can enter like this. I can put my needle here and I will go on transfusing. Let us see how this is going to be. I have given local anesthesia here, so there is going to be blanching. You keep your eye on this corner. I will enter. If you can see, my needle is here. I'll see my needle. I can see my needle here. Look at this. Look at this point, and look at this. This is where I have just entered my needle, and I will repeat this. I will repeat this because I want to show you how that entry has to be made. Let us see this. Okay, you can see this is my needle. I have entered just my needle here, and once I enter into the umbilical vein, like I'm showing, repeating this, at this point what I will do is what I have done is let's see this. I have withdrawn the blood here, and I have thrown the syringe to collect. And from these syringe, I'll get the fetal hemoglobin done, fetal blood group done, and a direct Coombs test done. I will attach a 3-way stopcock to the needle, and the RBCs you are supposed to push the RBC with the syringe till the desired quantum is being given. And once this syringe gets emptied, there is a 3-way stopcock. We'll withdraw it from the blood bag, rotate again the stopcock towards the fetus direction, push the RBC, because the hematocrit of this hemoglobin is almost 80% or plus, hemoglobin 21-22 gram. So once you are pushing, you will have this kind of velocity which will be shown on your ultrasound machine. So that is what is there. You can always desired quantity can be given. This is what you have got, a posterior placenta, and in the posterior placenta again what I can push the needle right in the posterior placenta, right in the cord, and that desired quantum can be given. The third is a free loop. I can anesthetize the fetus with tricurium and inject the desired quantity of there, or I can give it in the hepatic vein until the time desired quantity can be given. So this is the needle right up to this, and that's how I will give you. O negative has to be given, must be tested for HIV, HBCG, hepatitis E, C, and everything. CMV seronegative, leukodepleted, fresh blood, and irradiated. These are the specifications by which I should have those kind of things. But remember one thing, that 3.3 gram of hemoglobin or 1% of hematocrit is going to be reduced every day. So 7 days, 7% of hematocrit, 7% of hematocrit means you are talking about the 2.3 gram of hemoglobin, and that is going to be reduced by that time. So delivered after 35 weeks, you can have many problems if you have got a posterior placenta, fetal hydrops, multifetal pregnancy, early gestation because cord size may be small, fetal anesthesia, or timing of delivery would give you quite a lot of kind of outcome. Occasionally, the technical problems is you may have some kind of angle which are going to be there. You have got only look at this here. If I see that this is the membrane of the placenta and this is the cord attachment, I have got only this much of distance, hardly 2 millimeter distance. I don't have any error to play. And see this, my how much careful I have to be. So this is before going there. That is again one of the important point. Just with a small thrust, I can go in. Now I am in the vein. So that kind of difficulties, or occasionally baby can be notorious. And look at this. Here I'm just doing my transfusion, going smooth, very smooth, and baby's hand has started grabbing the needle. If you can really look, baby has started moving, and baby will try to kick the needle out. See this. This is baby's hand. It wants the needle to go out. So this is what you can have occasionally. These kind of problems you may end up. So there are few things, do's and don't do's for the fetal transfusion. That's what this will come with an experience to you. We have already more than 650 transfusions till date. That is one of the highest number of transfusions which are done in a private setup with more than 80% of the success. And I would definitely like to tell you couple of things that we have given world couple of new concept as far as you can increase the hematocrit target from 45 to 55. That is our way of thinking, and we have published in international world congresses. This is after 2 transfusion. Instead of 1.5 mom of the MCA PSV, you have to evaluate at 1.7. That's what the thing what we have already given to the world, that's how you should evaluate them. Now you can also reduce, you can improve, the outcome by couple of changes, which I think I would skip this because there is already we are running short of time. There are no critical levels. All levels are critical. Make sure that you evaluate fetal anemia, not 1:16 or 1:32 or 1:256. It's an fetal anemia evaluation after indirect Coombs. If indirect Coombs is negative, try and see that lady doesn't become immunized. And if she's already ICD positive, your job is to identify fetal anemia before it develops hydrops. And if already hydropic transfusion, before severe anemia develops, you should offer them the fetal transfusion. If you are doing, fantastic. If you are not doing, refer at appropriate center so that they can carry out the fetal transfusion. So this is what I wish that most important step is proper management of Rh negative mother, and that is what you all you should take care of this. Thank you very much for patient hearing, and I hope I'm okay with you.
Thank you very much, Prashant sir, for your. Thank you very much, Prashant sir, for your elaborative talk on Rh immunization. Friends, if you think of Dr. Acharya, the first thing comes in your mind is fetal medicine. But now, I hope every one of you must be agree with me that genius is always genius on all fronts. Sir, your talk was par excellence as always. High-risk pregnancy has always been a topic of interest because as an obstetric consultant in a small place like Yavatmal, and we are facing a lot of clinical high-risk problems in our day-to-day practice. Rh isoimmunization is one of the problems we are facing in our routine practice. As Sir rightly mentioned about the counter sale of Mifi-Mizo, plus in the rural areas, most of the patients in their antenatal period are taken care by Anganwadi Sevikas, government staff of THC or RH. Unfortunately, some patients are not done with the basic blood investigations like CBC or blood grouping. In few patients, they proceed for spontaneous abortion or deliveries without the knowledge of blood group. And many times, the Rh negative patients are delivered by the people with no knowledge of this topic. In such scenario, the Rh negative patient can face lot of trouble in their future pregnancies, as Sir enlightened in the talk. One more point I want to add. If a Rh negative mother delivers a Rh positive baby in case of multigravida or one who is completing her obstetric career, she is not willing for further childbearing, still she should be given anti-D injection within 72 hours because in future, if there is any issue of organ donation between mother and child, these antigens can cause trouble. Once again, thank you very much, respected Dr. Acharya sir, for your excellent talk. At the outset, I would like to extend my sincere thanks to the office bearer of ISOPAC, Dr. Milind Shah sir, Dr. Sneha Bhuyar madam, and the convener of the CME, Dr. Lakshmi Shrikhande madam, for this opportunity. Over to you, dear MOC.
Prashant, very well delivered talk. I'm really happy that you agreed on such a short notice. As of now, there are no questions from the audience side. Yeah, everyone is appreciating your videos and your accurate insertion of the needle in the umbilical cord. So, Parul bhai, you want to say something?
Well, I do not have many things to say. Prashant, it was an excellent deliberation.
Thank you.
Only one point I want to highlight, and that is this 72 hours dictum. See, there is no science behind it. It was only the first clinical trial which were undertaken in that trial, they had put up that within 72 hours, they will give the NTD. So there is no logic behind it. It was only their method of conducting a trial.
See, it is about
So we should give as early as possible.
Yes, as
and as early as possible. But even if it is given later, up to 15 days, it doesn't matter. It will still be effective.
It matters much. It's about the almost complete coverage will happen only if you provide her as soon as possible, up to within 72 hours. It is said. If you are late, there are more chances of being failed in that covering that lady to becoming isomionized. So more after 10 days, the chances even goes worse. So that's the reason it is said that up to 10 days, fair enough. But best is within 72 hours, then up to 10 days, and after 10 days, there is no point in giving her these NTDs. So it is like this. Yes, there is going to be a difference in the.
My point is that only that as early as possible, because many times, see what has happened is many times if a delivery occurs on Saturday, people wait till Monday. 72 hours are not yet over, so it is okay. Don't do that. And if it is feasible to give it early, do it earlier. Don't wait for 72 hours. That is what I want to make a point.
Yes, that's correct.
Otherwise, later, if you have forgotten or by chance it has not been given, then even later is also okay. Okay, I think let us get on with the program.
Yes. Thank you. Thank you so much. Now let us move to our much awaited panel discussion. So I will share the screen. Now we have Dr. Alka Mukherjee here with us. Alka, please introduce the moderator, panel expert, and the panelist. I will display the slides. Just a minute.
Yes.
Yeah, Parikshit Tang, moderator. Yeah.
After these two important presentations by Dr. Lakshmi and Dr. Prashant, let's move on to the panel discussion on a very important topic, that is obesity and pregnancy. We all know obese women, they pose a lot many problems, risk factors to themselves and to the treating obstetrician. To solve all our queries, we have a moderator, Dr. Parikshit Tang, and panel expert, Dr. Sneha Vyar. So here I am introducing the most well-known face in Foxy, Dr. Parikshit Tang. He is a consultant Ashwini Maternity and Surgical Hospital and Endoscopy and Assisted Reproduction, Mumbai. He is consultant Jupiter Hospital, Thane. He is honorary professor at Pacific Medical College, Udaipur. He has many affiliations. Right now, he is joint treasurer of Foxy and chairperson Safe Motherhood Committee, Foxy 2014 to 17. He is on managing committee member. He is a managing committee member, Mumbai OBGYN Society. There are many awards and publications to his credit. And to name a few, Dr. K. Bhaskar Rao, gold medal for first place at DNB. Dr. Kamini Rao, Yuva Foxy orator, 2011 and 12.
Alka, I think, we can let all this go.
Okay, sir. So nice of you. Thank you, sir.
As usual, very humble, Dr. Parikshit Tang. Welcome.
Sorry, madam.
Yeah. And second important personality today is Dr. Sneha Vyar.
I will take the small introduction because the time is less.
Yeah, you can introduce in 2 lines.
Our founder president, Dr. Sneha Vyar, she is a well-known face in Vidarbha as well as in Foxy. She is a great friend of mine, always helping and caring. The next, coming to the panelist, Dr. Yashodhara Pradeep. She is a professor and head OBGYN, Dr. Ram Manohar Lohia, Institute of Medical Sciences, President LOGS. Thank you, ma'am, being there. Next is Dr. Manjusha Shah, my partner in quiz, I believe. West Zone Chairperson ISOPAP, Consultant Anesthesiologist, Solapur. Next, Dr. Palini Appan, he is a professor and unit head Department of OBGYN, Sri Ramchandra Medical College, Chennai. Next, Dr. Jyoti Malik. She is a medical superintendent, GJ Hospital of Medical Sciences, Bahadurgarh, and director of Roots IVF and Fertility Institute, JJI MS. The face of Foxy, young face of Foxy, Dr. Niharika Malhotra. She is an infertility consultant at Rainbow IVF Agra and practicing obstetrician at Malhotra Nursing Home. Next, Dr. Ritu Santwani. She is having a 20 years extensive experience in obstetrics and OBGYN OBGYN with a specialization in cosmetology and IVF. And she's passionate about sharing her knowledge. Welcome, Doctor. Welcome all the panelists, moderator, and panel expert. Thank you so much.
So
Over to
I'm
you.
just going to start sharing my screen, and a very good evening to all the panelists who are with me today. And I must thank all of you for your kind participation. Let me begin by thanking Dr. Lakshmi Srikhande for the invitation to share some thoughts about this topic. And indeed, I think there's no shying away from the fact that this is one of the important and emerging issues which is coming up in obstetrics in present times. So, having said that, let me just outline the panel. It's a general discussion, and I'll follow that up by a case-based scenario. It's a vast topic, and it's a very wide coverage because it encompasses so many medical conditions, so much of obstetrics. I mean, it could literally be a book. And I'll try to focus on some specific questions to enhance our clinical learning and practice. And I must confess that I can only make it a tasting session. I can't make it a full meal in the next 45 minutes. So if I leave out something, I'll just keep 5 minutes at the end where all the panelists can chip in and give a take-home message, and especially try to cover what I might have missed. So let's begin with an overview, and let me ask Dr. Yashodhara Pradeep. Ma'am, what are the currently accepted definitions of obesity? I mean, typically we look at weight, but what should we really be looking at?
Dr. Parikshit, good question, because it's one should know about it. So it's a abnormal fat accumulation in the body, which causes the health issues. And the BMI, which is being said, because we go with the BMI, is calculated the weight divided by the height meter square, and that is how we get. So if we are under 25, we say it is a normal weight.
Yes,
it's a WHO. And if it is 25 to 29.9, it is said overweight. If it is 30 to 39.9, it is said that it is a obesity, and then it is being said that it is a morbid obesity. They have also classified as class 1, class 2, and class 3. But the NHS says that in pregnancy it is different, because the class 3 morbid obesity classified by the WHO is when it is 40 to more than 40. But for the pregnancy, it has been taken the morbid obesity when it is more than 35 kilogram per meter square. So I will go with it that if any woman who comes to your clinic at the first antenatal visit, her BMI is more than 35 kilogram per meter square, I'll say she's a morbid obese, and we should start treating her with a specialist care. She should not be treated at PSC, at the community hospitals. She should be referred to the clinicians who are having a tertiary care hospitals in their this thing, and very knowledgeable about it, because otherwise we are putting this woman on a lot of.
We should actually calculate the BMI.
Yes.
I think, all clinics will do a weight and probably just leave it at that. But I think the important take home from Dr. Yashodhara's response is that it's not just the weight, it's the BMI which needs to be calculated, and the risk needs to be stratified accordingly.
Yes.
Absolutely, I agree with you. Let me go to Dr. Palaniappan with my next question. In your practice, do you see more obese women now than a decade ago? And I'm also going to put the same question to Dr. Manjusha, because she does anesthesia, and I'm sure she also must have noticed some changes in the epidemiology. So, Palani, I would like you to respond first, and then Dr. Manjusha, please.
Thank you, Dr. Parikshit. Wonderful, and thank you, Dr. Lakshmi, for involving me as well. Yes, Parikshit, definitely in my practice, we see more obese women than what we saw 10 years ago, for the very simple reason. I thought just before the COVID pandemic, 10 years back, we had an obesity pandemic, and I think PCO and the obesity and these women becoming pregnant, or they have been made pregnant, And so, and then left to the lurch of the obstetricians, especially the ones in the tertiary care center. So the referral letter comes saying morbid obesity, and then we need to manage them. So definitely there is an increasing trend of obese women becoming pregnant as well, and not becoming pregnant as well. But then, yes, we are seeing an increasing trend of obese women becoming pregnant, and it becomes a tough issue to manage them, because we did not have webinars and such topics some time back, but now, yes. And so we are all quite familiar in managing obesity in pregnancy.
Dr. Manjusha, what do you feel?
Yes, there is alarming that is the percentage of morbidly obese women is doubled. Because the increasing in Indian scenario, increasing trend towards obesity in Indian women from 10% it was in 99, and it has increased to 14.6% in 2005. So again, there is a regional variation in obesity. That is, in Punjab it is more as compared to Kerala and Goa. So it is increasing in right.
Dr. Shah, your voice isn't that clear. Do you think we can do something for that? Because I'm just hearing you very faintly. Maybe earphones or something?
No, actually. Is it audible? Is it?
Yeah, that's better. That's better. Thank you so much. Thank you.
Can I repeat?
Yeah, I think we got what you wanted to say, but I think, coming close to the computer helps, so that it becomes much more clearer. Thank you. Dr. Malik, let me come to you. Both the panelists have agreed that yes, we are seeing more obese women now than what we were seeing earlier in our practice. Do you think the trends are similar globally and in other developing countries?
Yeah, good evening, sir. Thank you so much. And thank you, Dr. Lakshmi. Actually, I read a lot on obesity. Otherwise, I was not reading. And this panel made me really go through obesity and pregnancy. So thanks to all of you for it. Definitely, obesity is a growing problem in India. And universally also, as Professor Palanai Appan said, that there was a pandemic of obesity. So this pandemic is still continuing, and because of obesity, we have many other associated problems along with it. And definitely, because maybe it is all because of that genetic problem that those roots have come up now, and those girls, the mothers who were obese, now those girls are into their say puberty and developing PCOS and becoming young mothers. So those are the girls. Maybe they are.
Sure. So I think India is in the trends in India and what we are seeing.
So all these are actually contributing.
Yes, that's correct. Sorry, I think we've got a little bit of a difficult connection with Dr. Malik. It's snapping off a little. Let me come to Niharika with the next one. We all agree that obesity is a problem. We are getting more obese patients. But why is this? Niharika, what are your thoughts on this? Why is it such a growing problem?
Thank you, Parikshit sir, and thank you, Lakshmi ma'am. So yes, we were discussing about obesity, and I also read an article recently which said that almost 72% of men and 80% of women are obese in this world. So that's like a huge number which I read by WHO, and they said that more than BMI of more than 30 is going now drastically increased, and it's been tripled. And most of the common causes which we are now thinking is, first of all, COVID actually also has played a role because of physical inactivity and overeating. Secondly, genetics is playing a huge role, especially for India. We are seeing that mothers who are obese have children who are obese, and then the cycle just keeps on going. Third, our diet form in India is basically carbohydrates, and I feel that also plays a very huge role. Fourth, I feel because March 20th was the International Happiness Day, and India is very poor on the happiness quotient. We are almost 139th, and that is also one place that psychological factors do come into play for obesity. So these are one of my things which I feel are the causes.
Yeah, I think you've really encapsulated, the whole gamut of what is leading us to a population which, of course, we all know that undernutrition is a problem in India, but overnutrition is becoming almost as much of a serious problem in our country. Ritu, I think, there's a lot which has been said about the problem, but I think there are some important steps which have been taken at a social level, at a national level. So if you could please mention and, just talk briefly about the important social and national programs that are meant to address this issue. Dr. Ritu Santwani, if you're there, please. No, I think she's probably not logged in. So let me ask Dr. Yashodhara Pradeep if she would like to respond to this, ma'am. Ma'am, you need to unmute yourself, please.
Yeah.
Thank you.
There are many government programs are going through. Posha program is one which is going in the India. And it is basically for the undernourished people, not obesity, because it has been said, yes. Because there is a class where we are still having our 60%, more than 60% population living in the villages.
Yes.
And obesity is not that common there.
True.
Globally it is common.
Yeah.
In some part of the India, it is also common. It is probably 10% or something. But the growing population, which we are going to see after 20 years probably, this population will grow a lot. So at the moment, we are having more programs, Posha India, for the undernourished, for getting the nutrition.
There is a small push towards, trying to make people more fit. There's a Fit India program and things like this. But, it's just at a very, very rudimentary stage.
Yes.
And I think probably in the years to come, hopefully, we become a little more fitter nation. So,
of course, at the personal level, or it can at the social level, we are organizing many programs, the marathons, the sports, this thing. We are making more aware. But at the government sector, it is still rudimentary. We are still facing a problem for undernutrition. Our children are really undernourished. And so we are having, you must have seen, there is a decade in which the children had a very less height just because they could not get the good nutrition.
Correct.
I will say that if you go 20 years back,
those are
30 years back
as well. Yes.
Yes.
So
but
let's
now it is
come to case one, and now we've got a 29-year-old woman and her husband who have come to your clinic, and they are here for preconception care. She has regular cycles, no long-term health issues known. Her weight is 90 kilos and she's 5 feet 6 inches tall. BMI works out at 32, and she's quite aware of her weight. And, she's here to seek your advice about how to go about further. So I'm going to request Dr. Manjusha that, because we don't have a physician on the panel, you're going to double up as a physician also. But first, let me ask Dr. Palaniappan, what are the main things, what are the highlights in terms of the important medical conditions that we should be looking for in this woman?
Yes, if this is the question to me, I think I would look on to the medical conditions in this particular patient as diabetes mellitus first, hypertension second, multiple pregnancy, yes, a little bit of risk because of the obesity. Little later, maybe preterm labor, and then I went them into intrapartum and postpartum complications as well, in the sense of shoulder dystocia if it's going to be a big baby, and then increased vaginal delivery, operative vaginal delivery, increased C-section rates, and then post-operatively, owing to her immobilization, probably thinking in terms of venous thromboembolism, which I'm sure we will discuss in the future questions. So, spread across all these are the medical conditions that would come to my mind in.
Yeah, absolutely. I think that gives a very nice, kind of an overarching framework. Probably that kind of covers everything that we are going to discuss in the panel. But those are the really important highlights that we would be looking for. Dr. Manjusha, how would you assess her from the point of view of cardiovascular fitness?
Yeah, actually, in these patients, obese parturients, ECG and echocardiography, that is more important because of this hypertension and preeclampsia. These patients, they may have this PPCN, that is postpartum cardiomyopathy, may come in these patients. And so it is very important to rule out all these things like cardiologist opinion about these patients morbid, because 32 BMI is morbid obese, moderate or severe obesity. So we can consider for this fitness.
Right. And as I said, you'll have to double up as our physician, not only as the anesthetist. If she happens to be hypertensive, let's say her blood pressure in the clinic is 150, 100, you ask her to monitor it over a week, it still remains at that stage. What would be the drug of choice for controlling the hypertension? She's planning to have a pregnancy in the near future.
I think it is a beta blocker. That is the drug of choice that we can consider.
Right. Any other opinions on the choice of drug?
Yeah, I will say that depending upon what is her reproductive choices, if she is going to get pregnant in the recent.
She's for preconception care.
Yeah, she has come for the preconceptional care, so probably we will go for the other drugs, which are labetalol at the moment is we are using the most. Yes. Because she has come for the preconception. Methyl-dopa, yes, we can use, but it is not now available. Most of the
that's become a problem, absolutely.
And it has become a real problem because we have used for so long.
Yeah.
And nifedipine can also, calcium channel blocker can also be given.
So number of choices: beta blockers, calcium channel blockers, centrally acting agents. There's one group which you don't want to use, and that is the angiotensin receptor blockers.
Yes.
Besides that, most drugs will be all right.
Yeah, beta blocker also we do not mostly use it for the preconceptional care because beta blocker and this thing.
So alpha plus beta, like a labetalol, is probably all right.
Yeah.
So Dr. Malik, this girl, her lipid profile shows a cholesterol of 350 milligrams. Triglycerides are high, 245. You send her off to a cardiologist. The cardiologist tells her try to lose some weight, but in the meantime start statins. And that's a pretty common prescription which cardiologists will give. Are they okay in the periconceptional period, or would you advise her not to take them?
Actually, at this particular time, I would like her to at least lose weight, take care her, control her, get her BPs under control, get her cholesterol and triglycerides under control, and then she should plan. So in this particular period, while I would in fact prefer let her start folic acid on her, maybe start with some vitamin D as well. So that, and also not to, she should not be conceiving at this time. So maybe at this particular time, I will advise her to control all these things, and then maybe
and
she can.
What about the statins? Are they okay to go, and then you'll switch them off when the urine test turns positive, or how do we go about that?
Then that is why she should not conceive, because she is on statins just now. So,
okay.
Yeah, I would not like her to conceive with statins on.
Okay, so preferably not to take them.
Yes, statins are class, not a category drugs which can be used.
That's one of the important co-prescriptions, yes. And we need to just acknowledge whether a woman is taking that or not. Niharika, this girl gives us a history that she's got poor sleep, very disturbed. She feels fatigued, tired, she's listless, she's reduced a number of her activities, and she tends to be dull. So, given this and her weight, what conditions should we keep in mind, when we are addressing these kind of complaints? Fairly common clinical scenario.
So most of the patients who come with obesity will give you this history, and they are going to show that lethargy, especially. And these patients usually have a very disturbed sleep cycle because of the hormonal disturbances which have happened in their cycle. Because we know that the fat cells actually secrete a lot of estrogen, and there is a disbalance between the estrogen and progesterone, where all these problems do happen. And such patients who give us a lot of history are more prone to having more complications at a later stage, especially with
Yes, absolutely.
diabetes and preeclampsia, and they will also
Yeah.
give us complaints of sleep apnea.
Yes, and that's one of the important differentials in this condition. The second one, I think, could
Thyroidism
probably
also.
be hypothyroidism.
Hypothyroid
Yeah.
should also be investigated
Hypothyroidism.
in this woman.
Yeah,
There is
yeah.
there is an elephant in the room which we usually tend to ignore, and those are mental health issues. I mean, sometimes pregnant women who are obese might have body image issues. They might be depressed. They might
Yes,
be
very right.
anxious because they aren't getting pregnant. So
Very
all
right.
these also need to be kept in mind, and we have to acknowledge that they do affect pregnancy outcomes.
Yes.
So let me bring in Dr. Sneha Bhuyar at this point and get her, inputs on the highlights till now on this woman who's come for preconception care. And I want her to start off this discussion on the strategies to optimize BMI.
Thank you, Dr. Parikshit. At the outset, I would just like to just go a little back as far as the physical activities in general is concerned. Just to have a little acknowledgement of the WHO policy of NCDs. 2004 and 2011, we have a global policy of NCDs, and I think recently we had the conference also on that. So just to remind about the NCDs which are covering obesity as well. As far as this woman is concerned, I think preconception counseling should start with optimizing her BMI, and that should take into consideration her diet pattern, her activities, as well as her behavioral issues. So mental health is also to be considered. Diet should be not crash diet. We have to modify her diet, avoid junk food from her food, have lots of water, fresh fruits and vegetables, and we have to calculate her BMI, see how much excess fat and body fat as well as body weight she has, and how much should be the optimum weight for her. Even if she loses 5 to 10% over first 3 months, I think that should optimize her BMI and should regularize her ovulatory cycles as well. That should be helpful for her.
Yeah, thanks, Dr. Bhuyar. I think those are very important inputs. It starts with sensible eating, and then you take it forward from there. Let me come to Dr. Malik. You were mentioning some supplements, folic acid, multivitamins, especially vitamin D, probably does have a role. But we all want a quick fix, and so does this woman. So, are there any medications which would help her to get her BMI in order, and which we can prescribe her?
I don't think, except for diet and physical exercise, supplements at this, maybe I would not recommend her. I would not be
Absolutely. I think that's a very important take home. There's no quick fix. It's hard work all the way, and a change in the lifestyle drastically is what is going to lead her to a state of optimal health. And here's a very common question. I'm sure all of us in clinical practice have faced this kind of questions, that she's concerned that you are advising her to exercise, and then she's trying for a pregnancy too. So will exercise affect her chances of miscarriage? What would you advise her?
In fact, it will improve her chances of miscarriage. pregnancy continuation, in fact.
Yes, absolutely. And I
And the
think that's
better
a very
outcome of the
important,
pregnancy will be there if she
important
loses
point
some
that we
weight.
need
And
to emphasize, that we need to emphasize.
yeah.
Yeah.
And
Dr.
her,
Malik did speak about this, and I think this is probably the most difficult question for case number 1. Should she defer the pregnancy until the BMI is optimal, or should she start trying to lose weight and try for a pregnancy simultaneously? I just want a show of hands as to who would want to defer a pregnancy amongst my panelists.
No.
No deferring.
Like to defer the pregnancy.
You would like to defer. Okay, great.
Yeah.
So,
it should be
as I said,
simultaneous.
this is a thorny
Simultaneous.
issue. No perfect answer. I think let me just put in my 2 bits. What I tell women is that, have you been trying to lose weight, and how successful have you been? So if the answer is no, I've never tried, then well, it's fair to give her 3 to 6 months, see what kind of progress she's making. But if she's been on a number of diets, a number of programs, weight's not budging, then well, it's not going anywhere, and then she might as well get on with the obstetric career.
I think, Dr. Parikshit, here we can say that if she's morbidly obese, where she's going to land up into various complications during pregnancy also, and during labor and postpartum, that time we have to intervene,
Yeah, fair
and maybe
enough,
we can
Yes,
defer.
those are exceptional situations. I agree. Okay, let's come to case 2. A 38-year-old woman has presented for her first antenatal visit with you. She's got a scan yesterday, 6 weeks live pregnancy. She's conceived with assisted reproduction. This was embryo transfer number 3. Naturally, she's quite anxious. Her weight is 86. She's 5 feet 2 inches. BMI is 31. Her general examination today, including the blood pressure, is fine. Everything is within the normal parameters. Should BMI optimization be mandatory before ART treatment? I think this goes from the previous question, and
So not because she is 38. This is the
Yes.
third attempt. We cannot waste time, and we cannot she's borderline. She's just 31 BMI. So there is no need of going for BMI optimization for this particular case.
Yeah, but we keep on emphasizing it.
Yes.
We should not ignore it. We keep on emphasizing it, but we should not wait to optimize the BMI. But at every visit, we should keep her giving the.
That she was on metformin treatment 2 years ago, and she used to tolerate it quite well. Would you start this agent just because she's got a high BMI at this stage of pregnancy?
There has been enough evidence to say that there is no role for metformin just for weight reduction. And if at all she's been on metformin for 2 years, I would only think that as a curse or a sin and say, please stop it and don't start metformin for weight reduction, because it's not a weight reducing agent.
Absolutely.
No.
But there's one trial that says efficacy of metformin in reducing the weight of in obese pregnant women. In obese pregnant women. In obese pregnant women
who have
Empower.
Yeah.
So
the Empower trial did say that.
It is only in the trial phase.
The Empower trial said obese women with diabetes.
Yes.
Not obese
women
with diabetes. Okay, not obese women alone. So that is.
So
this
woman also recommends that it should be used only when there is carbohydrate intolerance.
Yeah, and that's what I'm going to ask Niharika, that what screening tool should we use for her to make an early diagnosis? Should we do it at 6 weeks, or should we wait till the conventional time, when we usually do our first trimester tests?
Do it at 6 weeks.
Niharika, are you there?
Yes, sir. Yes, sir. I'm here.
Yeah.
So now we are thinking of screening her for diabetes, and actually screening should be done actually on the first visit as soon as possible.
Absolutely, very important.
And then we could repeat it again at 24 to 26 weeks.
Yeah. So I think we nowadays, I think most people are following the national guidelines on DIPSI. So I think we go with that and pretty much use the 75 gram 2R 140 kind of a cutoff. I think it's pretty well established. If this woman happens to be a diabetic who's not controlled by MNT, medical nutrition therapy, Dr. Manjusha, what do you think as a physician point of view? Do you think that the best choice would be insulin or should she take metformin?
She should go for the at the. I'm not sure about this actually because
Okay.
she's a 6 months.
Palaniappan, what do you feel? What would you give her?
This is a very perfect question for me and for this August audience. I think now is the time to change to metformin if you're thinking in terms of insulin. And we've been having enough evidence to say that metformin is safe in whether first, second, third trimester, doesn't matter. Insulin will enhance the obesity by affecting the insulin growth factors, whereas metformin will not produce obesity and more so in the baby as well. And so this is an ideal candidate to start metformin.
Thank you very much for bringing that point so clearly across, because you know the natural tendency the moment diabetologists get involved in the management of gestational diabetes, it's almost knee-jerk reaction. You start them on insulin. So I think we need to acknowledge that metformin is now a drug that we should be looking at as the first choice, especially in an obese woman. It's the ideal drug to start. Now, one natural question which every pregnant woman is going to have is, am I gaining enough weight? And this is one thing which is like a natural curiosity. So let me ask Dr. Bhoyar, because you're highly experienced as an obstetrician. This pregnant woman who's already on the heavier side has come. How do you advise her? I mean, it's a pretty sensitive issue because, the mother-in-law is going to tell her that you better start eating for 2 and 3. And how do you talk to her about this?
I will definitely first tell you what is practically how I advise my patients. We just tell her that just gaining your weight is not mandatory for the baby's growth as well. So, sorry, one second. थोड़ा अर्जेंट नहीं मी इकडे वेबिनार. So weight gain, how much it should be normal for the whole of the pregnancy? It should be 11 to 12 kg. But if your BMI is high, your recommended weight gain should be different from others. That is what initially only we should tell her. So we are advising her in such a way that whatever calories you are consuming, you feel adequate. Should not necessarily cause your weight gain. You just have appropriate calories, lots of vitamins, what we advise routinely, lots of fresh veggies and fruits and all these things. You try to have your diet rich in all these antioxidants and vitamins, but you try to restrict your calories. Weight gain is not necessary for you. You have adequate stores as well. Because we are monitoring you very carefully and your fetus is growing well. So at present, you need not worry. And for the BMI, of course, for obesity, you have different levels of weight gain per, how many kgs per month. So for the first trimester, we have 0.5 to 0.7 for a normal, or almost 1 to 3 kg for a normal weight woman. For you, it should be only 0.5 kg or maybe even less than.
This is the right approach to individualize according to what that woman is at. Palaniappan, I saw you raising your hand. You want to make a point?
I thought there are clear-cut ACOG guidelines.
Yes.
Say that it is limited weight gain rather than weight loss. That's the first we should say. So the minimum weight they can gain is 9 kg is what they can gain maximum, and minimum is 5 kg. So that is the recommendation of the ACOG at the moment. And so
for the obese woman.
For obese, this particular patient.
Yeah.
Yes, thank you, Dr. Palani. In fact, I was sharing the practical first and the theoretical, of course.
Before we go forward, I just want to mention that Asian race is a high risk race for the diabetes. So all pregnant women, whether they are obese or not obese, they should be screened at their first antenatal visit for the GDM screening. So that is, I just want to say that
the point is well taken.
The August audience, that it's a Asian race itself is a high risk factor.
Absolutely.
Yeah. And he has said that for the obese, the weight gain should be this, or for the normal woman, it should be 11 to 16 kg. It could be.
Right. Now we come to something which does create some confusion, some difficulties. She's 38 years old, so she's concerned about chromosomal abnormality. She's heard that there are more Down syndrome babies as women grow older. So, what is the impact of obesity on our standard aneuploidy screening methods? Are they as accurate or do they suffer? Dr. Pradeep, yes, please.
Yeah, unless we have got a BMI included into the test,
yes,
we cannot say that these reports are okay. And
so
especially the NIPT has become very common. And
yeah,
NIPT
so
has become very common.
Important for the serum screening.
Yeah, and because it is easy also, although it is a screening method, but still people are taking it as a diagnostic method. So everybody is planning to have a NIPT done. But NIPT is not, results are not confirmatory. They may be problematic because the DNA fraction in the blood may not be enough, which can give the correct report. Yeah. It needs 3 to 4% of the DNA fraction in the maternal blood to give the report. So in the obese mother, NIPT is not a choice of test for getting the aneuploidy screening done.
Another problem is the congenital structural anomalies which we might find in obese women. And Niharika, I want you to answer this. What could be the possible contributor? I mean, why does this happen? Is there a biological basis, or is it a performance problem with ultrasound, or do you think it's a combination of both these things?
So first of all, with obesity, it is definitely difficult for any radiologist to actually screen because of the fat, thick abdominal wall. So most of the ultrasounds, when they do not give us a full report. They'll say that this scan was compromised because of the obesity. Yeah. So therefore, we will not be able to completely rely neither on the NIPT and nor on the structural ultrasound, because even with NIPT is the same issue. They say fetal fraction reduces in obesity. So both of the problems are because of obesity mostly.
Yeah. So I think, however much we try to optimize fetal assessment, there's always going to be a bit of lacuna over there. And this is something that we'll have to kind of accept as a situation with pregnant women. In due course of time, the pregnancy advances, and now she's at 32 weeks. Dr. Malik, she's coming to the clinic. She says that fetal movements are less, they are reduced. So is this pregnancy at a higher risk for perinatal loss? And how would you assess the fetal status in this situation?
Yes, right from the time the pregnancy starts till the time patient delivers, this obese patient, both the mother and baby are at risk. And definitely there is always a greater chance of having stillbirths and intrauterine growth retardations also during this in women with who have obesity or morbid obesity with pregnancy. So definitely, if she has a reduced fetal movement, we have to subject her to the ultrasound and look for the fetal, look for LICA, and also do a biophysical scoring, because now she's 32. We can do a BPS here and see what is the whether there is what is the fetal weight, what is the amount of LICA, and is what and any cord round neck. So, or any placental insufficiency.
I think the important thing is not to dismiss it off as, okay, you're obese and that's why you probably feel less movements. She deserves an assessment even if she comes repeatedly, because this is a pregnancy which is at risk for perinatal loss, and it should be taken in that sense. Palaniappan, the last question in case number 2 is for you. Should we deliver this woman a little earlier than other women? I mean, say your usual protocol is 40 weeks. Would you do it at 39 for her? And if yes, why? If no, why?
Fine. So I think, yes, I will plan her delivery right from 37 weeks or so, for the very simple reason that she's obese and she's at a situation of loss, and we have reached a term at 37 weeks. It's not that I will deliver her at 37, but I will plan for delivery at least from 37. And I will not allow her to go beyond term. There's no doubt about it. And for the very simple reason, post-datism would increase her shoulder dystocia, meconium, etc. And doing a section, etc., also would become difficult. And so we would be playing around with time. So I will plan her delivery a little earlier than any other patient. Definitely not preterm, but wait till 37 weeks.
So I think even though there aren't any guidelines which tell us to do this, it probably makes practical sense to do it at a time when help is available. Let this woman not come and deliver at 3 o'clock in the morning when the junior most residents are around. Let it happen during day when the seniors are available. Let it not happen too late at 40 weeks plus. So probably the truth lies somewhere, say 38, 39. That's when I practically would, consider delivering this woman. So let's come to case 3, 34-year-old, presents at 28 weeks. This is a second pregnancy, first one, a C-section for thick meconium, 3-year-old healthy daughter. In this pregnancy, she's gained 17 kilos and she weighs 84 kilos now. Her BMI is 28. So she's not exactly obese, but she's definitely getting there. She's overweight. Normal antenatal course, she's been euglycemic, everything's been okay till now. Her first question is, can she do a VBAC? Neharika, what are your thoughts? It's 28 weeks as of now. What do you talk to her about at this point regarding, VBAC or a planned C-section, or do you tell her to just defer the decision until we get a bit closer? Neharika, are you around? No, I think she might have logged off. So let me ask Dr. Pradeep for this.
Yeah, she's a second gravida, first C-section. First C-section is not an absolute indication for doing a repeat C-section. She is not overweight, she is not obese. So if she is euglycemic, if she does not have any other factor into which obstetric indication, and she agrees the informed consent, we have to see other things also. What is a interconceptional delivery to conception interval? We have to see that. She's 3 years, so it is also good. So she can be given a trial for the VBAC because we have to inform her. These are the chances, because we know for C-section, there's chances of repeat C-section is nearly 50 to 60%.
Correct.
So if she agrees, she wants to take a trial, yes, in the settings where there's a monitoring is available, she can be given a chance of monitoring, and she can change her decision any moment. The obstetrician can also change that.
Of course, we've got to be flexible on that. And that's what happens. At 37 weeks, her ultrasound from last week, already a 3.1 kilo baby, otherwise normal parameters. Fetal head is not yet engaged. I mean, what do we do? I mean, she's term now. Do you advise her?
Second gravida, the fetal head engages only in the labor, not before that. Even in the primaries, also it is only 40%.
At this point, or do I have other views that you would encourage her to have an elective repeat?
I'll say that if she is willing for the VBAC, because if she has asked for the VBAC, I will give her VBAC.
Okay.
This thing, because it is only 3.1 kg, it is only 37 weeks, and fetal head engages only in the second gravida during labor. And there is even in the primary, there is engagement occurs only in 40% of the women. 60% women do not have the engagement prior to labor, which we think that all the women may be having the engagement before the labor. It is not so, but we should give that because of the little bit overweight and the previous C-section. Your chance of repeat C-section will increase because we are going to induce 3.1 kg is also
let's say she hears that and she feels that no, I don't think I want to undergo that kind of uncertainty. She opts for an elective cesarean birth. And let me bring in Dr. Manjusha at this point. What preoperative investigations should we ask for? I mean, everybody gets a CBC and a urine and a bleeding time, clotting time, all that. Anything specific that we should ask for this woman? She's a bit overweight. Let's imagine that instead of her weight being what it is, she is 32 BMI or something like that. Anything specific, ma'am?
Specific all routine investigations and coagulation profile, that is again very important in these patients, and cardiovascular status.
Yeah. So a 2D echo routinely for this kind of a woman?
Yes, 2D echo.
ECG and a 2D echo. I think that might really, kind of complete the evaluation. Anyone else wants to chip in with their practice? Yes, Palani?
I think more than any pre-operative investigation, I think I'll make myself, my team, the theater, labor room, etc., get prepared, because we need a shifter and we need a separate cot with has a big hold 100 kg, whatever. And I think probably because of the increased respiratory work and myocardial oxygen requirement, she probably needs an epidural, maybe. So I will ask Dr.
Let's go to Dr. Manjusha with that,
Yeah,
because she's the
I
one
was
who's
just
going to
thinking
do it.
she's going to say that, and probably an appropriate BP cuff, because I thought her BP cuff will not suit her and the table will not suit her. And I think I'll start thinking in terms of retractors and things like that, because we need bigger retractors, etc.
Yeah, Dr. Manjusha, specific difficulties with anesthesia, and the next one is also for you. Say we are working in a an average-sized hospital. Maybe it's not a tertiary care, but an average-sized, well-equipped hospital. From the anesthesia point of view, what do we need to be prepared with?
Yeah, first and the most important thing is the airway. That is, assessment of the airway is very important in case of these obese patients, because pregnancy and obesity both they contribute to difficult airway. So a difficult airway card, that is, it should be ready during anesthesia, and all these equipment that are needed, like as Dr. Palnappan he already told that we need to manage with this BP cuff, then laryngoscope, long blade, epidural needles. All these things should be ready, and we need to assess for airway difficulty. That is again a major problem with anesthesia. So before posting her for cesarean section, in obese patients, regional anesthesia, that is the first choice of anesthesia for this obese patient.
And it would be great to have a helping hand, I suppose. Usually in a private nursing home, it's just one anesthetist who goes, but given the circumstances, it might make sense to call another anesthetist to just help out, because it's not going to be easy at all. Palaniappan did speak about some of the operative difficulties, and Neharika, I want you to just carry on from there and mention anything which comes to mind specifically.
I just did a cesarean a few days back for a very obese patient, and I was alone, so I had to call for help. And the first thing the anesthetist had problems with was the spinal needle. The length of the spinal needle couldn't go, so they had to give general anesthesia because she was so obese. The second problem was that we have to have an extra assistant to hold that fat. Usually we do it with one assistant, but for a obese patient, we have to be ready with extra set of hands there also.
Yes, that's invaluable. That's invaluable. Absolutely.
Dr.
Malik,
I think the thromboprophylaxis right from the compression, pneumatic compression device.
I'm coming to that. I'm just coming to that, Dr. Boyer. Just a second. Dr. Malik, you've done the C-section. Baby's fine, mom's fine. Everything's under control. How do you close the abdomen? What's your choice for the sheath and the skin? And do you use a subcutaneous drain usually?
My choice, obviously, I would like to sheath. I close the similar way. I use a Vicryl.
Okay.
For subcutaneous tissue, because the thickness is more than 2 centimeter, I always do subcuticular. I apply subcuticular stitches, and I try to close the fat and not leave dead spaces there. And I do not use a subcutaneous drain. And then specifically, I use staplers in these cases.
Right. Okay. So, I mean, these are questions to which, of course, there's no perfect answer. Lots of variation in practice. Some people would want a little prolonged absorbable suture material, especially if it's a previous C-section and obesity. So, maybe not Vicryl, maybe somebody might use PDS or loopethylone, something like that, and all sorts of materials which are available to close the skin. Right. Let's come to case 4, and I'm going to ask Dr. Bhoyar questions on this because this is a very, very everyday kind of a phenomenon that we might come across. So you're on your morning round routine. You're seeing a 37-year-old woman, BMI 34, third post-operative day. She had a C-section for a breech. Delivery post-operative was fine. Everything uneventful. But this morning she looks a bit short of breath, and she says that she's feeling a bit restless since the last 30 minutes or so. So, Dr. Bhoyar, what are the important conditions that we need to keep in mind when we are looking at this woman? Ma'am, if you could unmute, please.
Yeah. Is it day 3 you said? Is it day 3?
Day 3, yes.
Day 3. So, I mean, alarming situations, immediate post-op, we won't consider here, but definitely maybe little breathless, you said. So I have to start with milder conditions, thinking about, maybe her pre-existing anemia, or she has had excessive blood loss during or immediately after the surgery. And maybe because of that, she's having this problem. So whether she was hypertensive previously and now suddenly she has shoot up her blood pressure, or whether she is having some kind of thromboembolic episodes, which are, initial showers or maybe of that sort. Maybe this can be just the warning symptoms and signs. So all these lines I can think about it. And then, of course, further, when I evaluate the general condition and the specific investigations I would like to do. But if we consider this obese lady, as I said, during cesarean section itself, we can give we can use the pneumatic compression devices, or we can use the elastoprep bandages and the calf support. Maybe the calf pumping, we should do it regularly. We should encourage her for early ambulation, and maybe with support as well, much earlier than the usual routinely what we have been doing.
Absolutely.
And
I think
very
all
obese.
very, very important things that Dr. Bhoyar has put across in terms of differentials. It could be a embolic phenomena. It could be a postpartum cardiomyopathy. It could be hypertension on anemia, which was pre-existing, and it started worsening, and important clinical pointers. What should we do, immediately? My immediate reaction would be to call Dr. Manjusha, because the anesthetist is the best equipped to deal with this kind of a situation. Dr. Manjusha, pointers for clinical practice, in a nursing home. It's not a tertiary care hospital.
Regarding
Immediate steps that might help to, stabilize her condition.
Stabilize in way, you mean to say? Can you repeat, sir?
I would say immediately you support her with all the you shout for help. First, you call your anesthetist and physician first, and then call your obstetric colleagues and your staff, whosoever is around, and then you start managing. Simultaneously, you supplement with oxygenation, see that she's breathing properly, and you give IV medications, whatever necessary. Simultaneously, you send her investigations.
Absolutely. I think it's the ABC which always matters, and you've got to approach it in that sense. Dr. Bhoyar already spoke about measures to be instituted. One common practical question, Neharika, you operated on that woman who was obese. When and how should heparin be used? How long should it be continued?
Depending, actually, I did not use heparin in my patient. she was very comfortable during the surgery. But yes, heparin does decrease the risk of thromboembolic episodes, and it should be used, even can be given during the procedure when done, and of course should be ideally given till 6 weeks postpartum.
Depending on the level of
Yeah.
risk assessment in terms of the DVT score, so on
Yes.
and so forth. So I think it's got to be an assessment. It should not be a one-off. Yes, Dr. Pradeep wants to add something.
Yes, I just want to emphasize after my long experience, because we started doing the obese patients. I remember when I was a resident or something, very early consultant, there's a patient who came to us and my whole machine went off to the zero back, the weighing machine. So I was amazed. I did not, I have never seen it. She was so obese. And I remember that how I have done the C-section. But nowadays, it is a dictum that if the patient is obese, we should start the management of the VT thromboembolism prophylaxis should be given.
Yeah.
Because it is very essential, especially in the C-section when the woman is immobilized. So the stockings and the low molecular weight heparin should be given to her for at least 6 to 7 days or till the discharge of the woman. And recently I lost a woman who is being a C-section. She had either infertility, she was obese, and she was in the hospital for because of neonatal problem for the longer time. And then she was discharged. And you will not imagine that a week later, a relative came with the baby. Baby was having some problem. So I said, where is she? Because she became very close to us. It was new hospital, which I was building up and all those things. So she said, she's no more. I said, oh my God, what happened to her? She said she went to the bathroom and she did not open the door for a long time. So we just started a little worried about her and we found her dead there. So you can imagine, I cannot imagine any other thing except the embolism.
Yes,
because she was absolutely fine.
These are the tragedies that we need to prevent to whatever extent that we can.
Yeah,
of
Dr.
course, some are
Parikshit,
going
let me
to
finish
slip through
this.
the net.
And in the COVID-19, I have found this. I've saved 2 women just because the critical care team was there. So because these women also had the C-section, they were not very obese also. But in the routine C-section, we also keep this mind because they were immobilized in the COVID.
Right.
They were not allowed to go anywhere because nobody used to go and meet them and all those, everything was on the video calling and all those things.
I think we are coming towards the end of the discussion, and
we
I'm going to ask
timely
one of the most
intervened.
difficult
The timely
questions
critical
to
care
Dr. Palani
team
Appan.
intervened and they were
At
saved.
the postnatal visit, yes, the woman and the partner, they want to discuss contraception, and this is something which usually the junior most resident does, tells them that go and please use condoms. She promptly turns up after 3 months with asking for an MTP. So what choices can be offered to this woman with a high BMI? And let me put it the other way also, that what choices should we not offer?
PPIUCD, I will say I will try hard to give a PPIUCD.
OCP is not a combined OCP is not a great choice, but not at the postnatal visit anyway. If she's coming at the postnatal visit, levonorgestrel intrauterine system is probably the best choice which we can offer her. One, and if this lady is going to be a second gravida with the previous C-section and a C-section here, I would have anyway counseled her for a concurrent sterilization during cesarean section. The choice could have been given to her because we don't lose anything by doing a concurrent sterilization at that point of time. And if she's coming to, we've lost it for whatever reason, and she comes back toward the postnatal visit, condom is not a great choice. And OCP, of course, yes, no progesterone only pill is not a great choice. So we can offer her either a DMPA depot preparation once in 3 months, a long-acting reversible contraception, or probably I can think in terms of a levonorgestrel releasing intrauterine system as well.
Thank you very much. I think
I will try
that brings me to the end of the panel. I would like to thank all the panelists for their extremely valuable inputs, very considered opinions, and especially Dr. Bhuiar for her expert views. I hand it back to Dr. Alka for taking it forward and taking us to the end of the session. Thank you so much.
Thank you, sir.
Let me thank my co-panelists because I have to leave within a minute. So my co-panelist and Dr. Parikshit for putting such good questions to us and good cases. And it was very eye-opening. It was a very lively discussion. Everybody inputs were very important. Thank you so much. And Dr. Lakshmi Shrikhande, I am really thankful to her. She has, although I was very reluctant to come to this because I was really having tough time with the family commitments. But she has said, no, you must come. So I'm happy.
And I see a young one right there.
Yeah.
And I must appreciate your enthusiasm to participate. Thank you so much, Dr. Pradeep.
And second one is on the cradle.
Wonderful.
That. We could hear
Dr. Mukherjee.
Yeah. So I'm doing both the things together. So say bye. He just want to say hello to everybody.
Hello, Bacha.
Say hello.
Well.
Hello.
Hello.
Okay, fine. Thank you so much.
Yashodhara madam, thank you so much for logging in and joining us. Bye.
But that terminology of PID I like too much.
Chal, bara ho, Girish Laukar.
Yes, madam. Sure. Palani sir, hello. Jyoti madam, hi.
Hi, Girish. Hi.
Bye.
Okay, Alka.
Okay. It's always a pleasure task to propose vote of thanks as a secretary's job. So here I am with my job, and I personally feel that I couldn't do proper justice to the introduction of the team when I was introducing because the time was very short. So here I am with some different kind of thanks to all of you. My humble gratitude on behalf of Vidarbha ISOPA chapter to our guest, spectacularly pleasant persona, Dr. Sulekha Pandey ma'am, and prompt and knowledgeable Dr. Parul Kotadawala sir for being guest of today's webinar. My sincere thanks to this lucky smiling lady, Dr. Lakshmi Shrikhande, as our opening batsman of today's webinar, and perfect academician Prashant Acharya sir. Dil se dhanyawad to perfectly talented moderator Parikshit Tang sir, and smart and beautiful Dr. Sneha Bhuyar as a panel expert. My sincere thanks to the chairpersons magical Manju Shukla ma'am, magnetic and glamorous Manisha Ghate. I'm not able to see whether she's here or not. She's my good friend. Yeah. Mindful and beaming Manisha Barmade, and vivacious and multidimensional Dr. Brushali Mane. So coming to the prompt perfect panelist, Madam Gaikya, gratitudes to Yashasvi and powerful Yashodhara Pradeep ma'am. Today you did a commendable job. Magnetic and scintillating Manju Shasha, placid and authoritative Dr. Parini Appan, jovial and magnanimous Dr. Jyoti Mali, radiant and steady Dr. Ritu Santwani, as she was continuously trying to log in, though she was not here. At the end, I would like to thank all the viewers and delegates of today's webinar. And last but not least, my thanks to TOGS Bharat Seera. Thank you so much.
Niharika was also a panelist, Dr. Niharika.
Yeah.
Niharika,
She was
cute little.
Is she there? She's a new, young face, dynamic face of Foxy. Thank you, Dr. Niharika, too. Thank you so much.
Special thanks to Alka madam.
Palani, you can take one or two questions. Parikshit, are you still there?
Yes, I'm here.
Yeah, so please just go through the chat box. There are one or two questions like what problems should we anticipate during the cesarean of a morbidly obese woman? Then I think
Palani did speak about that, and so did Niharika. But just to encapsulate what they said, that problems could be there right from anesthesia. There could be practical issues like the size of the bed, the size of the retractors, needing a hand to just retract that abdominal wall, reaching deep down into the pelvis to get to the lower segment. Closing the abdomen might be a little difficult, more complicated than usual. So all these issues are likely to make it a little more challenging kind of a situation than usual.
I think, Parikshit, when you are taking the incision on abdomen, there also you have some technical difficulties.
Yes.
Because of the large panicula, no? Retraction is okay, but sometimes the umbilicus is so hanging below, so hanging down that you when you take the incision, it is almost at the lower uterine segment. I mean, that is so low. The umbilicus, when you are taking the transverse incision on the skin, it is very, very higher, you can say, because you feel that the umbilicus, which is actually low, the place should be higher. The actual place
So
of the
I think
which is higher.
it depends on the contour of the
Yes.
abdominal wall.
Abdomen. That's what I'm trying to
Sometimes-
say, that it is hanging. So you feel that it is this is the right place of the abdomen. So you're not supposed to consider the umbilicus, but take the
Absolutely.
incision in relation to the pubic symphysis. That is what
Very
the
true.
message I say.
Yeah.
So
May I add something? Dr. Parikshit?
Yes.
I thought the one on the panniculus, which Dr. Sneha was mentioning, was that there is a separate retractor called Alexis O retractor, which we panniculus. And so lift the panniculus up and put the incision as low as possible. And we'll have to keep that in mind. But you need to be careful, otherwise you will create a buttonhole in the rectus sheath. So panniculus needs to be lifted up, and there are special retractors, and we could use a special retractor. And of course, we need hands to retract the abdomen as well. And coming back to the anesthesia, I thought even getting an IV access line will be very difficult on an obese lady. So probably think in terms of a central venous line. Getting spinal would be difficult. Plan for an epidural. The airway would be difficult. So you could use a fiber optic laryngoscope. If at all, you may to intubate her and then post-operatively as well. And we discussed about heparin. And the next thing what I wanted to tell you was the closure of the rectus sheath. I think there is something called the Smead-Jones technique, where you take a far near and a near far way and then suture. Start from one end and then end in the middle, and then start from the other end in the middle. And it is advisable to use a non-absorbable stitch rather than a Vicryl or a PDS in obese lady because of the very ease with which the rectus sheath can give way and produce an incisional hernia owing to the panniculus also. So it's guideline, but it is enough that use a non-absorbable stitch, whichever is comfortable. And putting a drain is yes and no. And the skin, yes, of course, staples. Did somebody mention? Yes, we could use staples. And because of the obesity, it's a clean catch wound, no doubt. But still, we would give, otherwise, no antibiotics. But for this particular case, I think we would use cefazolin or cefuroxime 3 injections. And heparin, definitely 3 to 5 days for a vaginal delivery and 1 week post-operatively for a patient with, of course, early ambulation. These are some points which we probably not discussed. So if there are any improvisations, you're free to add on.
Let me ask one thing. Otherwise, also we take the incision in relation to pubic symphysis and not umbilicus, I believe. Is it so?
Yes, absolutely. But it's just that what Dr. Bhuyar was trying to point out is that sometimes, it gets a little confusing as to where to place the incision. That's all. So I think we've pretty much wrapped up the questions and the session. Thank you so much. Thank you so much, Dr. Mukherjee, Dr. Shikhande. And really a nice, great experience. Thank you so much.
Thank you.
Thank you, Parikshit, Palaniappan, Jyoti.
Thank you,
Manjusha, for staying till last moment with us.
Yes,
with
thank
the
you
host.
so much.
Thank you.
Thank you.
Thank you.
Well,
See you on
doctor,
some
thank
other
you so much,
platform.
sir.
Bye.
Bye. Bye.
Thank you, Dr. Lakshmi Shikhande. Dr. Parikshit, thank you very much for putting me in. Thank you very much.
Thank you.
Palaniappan, Parikshit, you were the magnet for Palaniappan to join,
we
I told him Parikshit is moderating.
I don't know why.